Good morning, everybody. I'd like to call the meeting to order. My name is Dan Elliott. The meeting today is entitled Newest Treatments for Hepatitis C, Whom to Treat and How to Pay. So again, I welcome all of you, and I'd like to begin by introducing Karen Shore. Dr. Shore is Program Director for the Institute for Clinical and Economic Review, that is ICER. She received her PhD in Health Services and Policy at Berkeley. Karen?
Thank you, Dan. Good morning, everyone. You hear me okay? So good. And I'd like to welcome everyone in the room. I know there's some folks down the hall watching us with a live webcast, and then we have lots of folks across the country watching as well. So welcome to everyone. I wanted to just go over a quick logistics announcements before we get into the substance of the meeting. So as I mentioned, there's coffee and snacks outside the door, so everyone help yourself to that. The restrooms are a little bit further down the hall on the right side. I think everybody's probably picked up materials as you came in. The panel has the agenda, the PowerPoint presentations, voting slides, speaker bios, and a couple other items. And then the public has the agenda, the voting questions, and the key tables from the report. So that will, as the panel is voting later this morning on the evidence questions and the value questions, they'll be referencing those reports. So you can do that as well as you're observing the discussion. So I want to just go over the agenda quickly. So you'll see we have a very action-packed day for 7 hours of together, and we're delighted that everyone is here. So we're going to start first this morning with a presentation of the evidence by Dr. Jeff Tice, Dr. Dan Elliott, and Dr. Jim Kahn from UCSF. So that'll be the first hour or so. We'll move into public comments then. We have, I think, 6 people signed up to make public comments. Then we'll break into a discussion where we'll ask some clinical experts from the audience to come up and talk with the panel about any questions remaining before they start with the voting. That will go until about 12:20, and then we'll break for lunch. So the public is welcome to go grab lunch downstairs. I know there's a Pete's Coffee downstairs and then other places nearby. So please just make a quick half-hour break for lunch. And then the afternoon will be a couple policy roundtable discussions. The first one focusing on clinical considerations around Hep C treatment, and the second around specialty drug payment and pricing. So those will be robust discussions, so we really encourage everyone to stay for those. And then we'll wrap up this afternoon talking about some recommendations to improve policy and practice based on the discussions today and some reflections from the CTAF panel. So with that, I'd like to introduce our president of the Institute for Clinical and Economic Review, Dr. Steve Pearson.
Thanks. Well, we're nothing if not efficient starting our meeting before 9:30. So, welcome, everybody. I just want to have a few brief words because this is, we really face a tough challenge today. This is a very difficult topic for CTAF. Yes, there are billions of dollars, if you will, at stake. There are lots of different companies, insurance companies, manufacturers, patient groups, and others who are interested in this area. And there are millions of Americans who are infected with hepatitis C. And these are people who, many of them are sick, many aren't, but they face a very serious future with their infection. And somehow CTAF has to embrace the fact of suffering and of sickness and of patients in need, and also wrestle with issues of limited resources, of healthcare delivery systems, the realities on the ground of providing care for millions of patients. And they have to do that all at the same time in a public setting. Because most of the time these conversations happen behind closed doors. Somewhere the different trade-offs are discussed, the different business opportunities are discussed, and it gets sorted somehow. But you've joined us today as part of an experiment. It's an experiment in social discourse. The mission of CTAF is to try to hold these important issues in mind and to grapple with them together in partnership with others. And in order to do that, what's going to be required? Well, CTAF knows from long experience that listening is going to be critically important. Listening to the experience of patients, providers, payers, and other policymakers, and trying to understand their perspectives. And it's also going to take a dialogue of respect, because I know that there are a lot of very strong opinions and emotions that can be generated by discussions of this type. But again, that's what CTAF is all about. It's an experiment, an important one, I think, for our country, and for obviously California in particular, in whether we can have these kinds of conversations in the open, talk about uncertainty, grapple with the humility that it takes to look at evidence when nothing is ever sure, grapple with, again, the needs of patients in a setting of ultimately limited resources. So that's what the goal is of today. And I just wanted to welcome all of you in the kind of partnership that we feel that we have with the public in our attempt to do this together in an atmosphere of respect. So thank you, and with that, I would like to introduce Dr. Jed Weisberg, Senior Fellow. Oh no, we're going to hand it back over, sorry, to Dr. Ulia, the Chair of CTAF.
Thanks, Steve. Just a word about CTAF. The mission, the California Technology Assessment Forum, CTAF, is a core program of ICER and reviews rigorous ICER-produced evidence reports and provides a public venue in which the evidence and value of healthcare services can be discussed with input of all stakeholders. CTAF seeks to help patients, clinicians, insurers, and policymakers interpret and move evidence into action for a more effective, efficient, and just healthcare system. Our vision is CTAF aims to create a future in which collaborative efforts to move evidence into action provide the foundation for a more effective, efficient, and just healthcare system. I want to say a word about conflict of interest. We have polled the panel, and none of us has a conflict of interest. In your packet, our definition of a conflict of interest is made explicit, so I would ask that all speakers state before their opening remarks whether they have a conflict of interest or not. At this point, I'd like to introduce Jed Weisberg. Dr. Weisberg is a senior fellow at ICER. He specialized in internal medicine and gastroenterology. He had a distinguished career at Kaiser, where he had the title of Senior Vice President for Hospitals, Quality, and Care Delivery Excellence, among other titles. Jed?
Dan, thank you very much. I'd like to recognize our chair, Dan, and our vice chair, Paul, who will be leading our panel deliberations. You will see that the panel does not have an easy time. We will hold up that bar of a social and civil discourse, and yet some difficult discussions and decisions will need to be made. We have a summary up on the slide as to what CTAF is and how it's funded, should there be any questions. And with that, I'd like to look forward to our topic for the day, hepatitis C. I think back to 1980, when I was a first-year fellow walking into a patient's room to do a liver biopsy. The patient had what was known at the time as non-A, non-B hepatitis, and I was doing the biopsy in order to stage the extent and progression of liver disease. I particularly remember that patient because in the course of the procedure, I stuck myself with a needle, had that momentary pit in my stomach fear, gathered myself, completed the biopsy, went to consult my attending, who told me there probably wasn't anything to worry about, but to get a shot of gamma globulin, which painfully I got. Didn't think about it, didn't get sick. Years later was tested, and thankfully am not infected with hepatitis C. But bloodborne infection, needles, have been the principal route of transmission and continue to be today. 1980 is not that long ago, and we were calling this condition non-A, non-B, which meant that all we really knew about it is that it wasn't hepatitis A and it wasn't hepatitis B. However, medical advances have been remarkably rapid during the succeeding 30 years. And hepatitis C was identified, tests were developed, the blood supply was protected, so transfusion-associated hepatitis went away. General antiviral treatment was first tried in 1986 when interferon was used on a small number of patients at Stanford. Interferon was subsequently approved, as were ribavirin plus interferon therapies, an improved, easier to administer form of interferon. PEG interferon was approved several years later. The scientific progress was remarkable. After the initial identification and sequencing of the virus from scientists at Chiron, assisted by the CDC, molecular targets were identified, the enzymes and proteins required for the life cycle and replication of the virus were understood, and drugs were developed. Actually, a number of the people in the room here today materially contributed to that progress, and for that we thank them and will recognize the clinical achievements later. Vaccines are in development, but are not yet in widespread clinical testing and are likely several years away. And as many of you know, all oral combinations of direct-acting antivirals are now coming onto the marketplace. In our last review, Dr. Tice referred to some of those that were coming along. Now the FDA has acted, and we anticipate more FDA action over the course of the next weeks, months, and short number of years. We're going to talk about today how we bring the remarkable advances in biomedical science to the large number of patients who are infected with this hepatitis C virus. Some of the complexity deals with the fact that the natural history of the disease is a long one over the course of decades, and biomarkers to precisely identify which patients will do fine with their infections and which ones won't don't yet exist. The drugs that we have been getting safer and more effective, and yet at the same time do put a cost burden on the healthcare system. Thus, we come up against the societal issue of whether we incorporate this new technology and watch the cost of healthcare increase, a movement which is not accepted by large portions of society, whether we can somehow figure out how to make room in our healthcare budgets and accommodate the cost of these new drugs, or whether we can rely on business and governmental and regulatory and other kinds of mechanisms through which we can somehow deal and accommodate with the financial impacts over time of these new agents, this one being the first of many, not only for hepatitis C, but for neurodegenerative disease and many other unmet medical needs, which will be addressed by advancing medical science. So this particular session today really crystallizes that societal discussion. We will hear how we bring together careful review of the clinical evidence, both of effectiveness, discontinuation rates, tolerability of treatment, adverse effects, as well as detailed cost-effectiveness analyses, and how some of the financial impacts are actually starting to play out in real delivery systems, including the California Medicaid system, Medi-Cal. We'll hear from private insurance companies that are grappling to bring treatments to patients, as well as clinicians who are trying to figure out how to take the small number of patients that currently are under treatment and consider expanding that pool and in what order they will bring patients into the healthcare system. At the same time, we recognize that several noted organizations have recommended universal screening, age cohort screening for the baby boomers. Thank you. And if that happens as planned under an active kind of protocol, far more patients will be identified as carrying hepatitis C virus than are currently known. Another huge impact on the healthcare system. So all of those issues will be considered by our panel, who you see in front of you today. They are a group of wise and thoughtful people who have read our full report and discussed it on a variety of conference calls. Try as we might, keeping these reports under 100 pages is difficult, so these folks have done their work, and you will see the results of their thinking. We are also supplemented by a variety of both clinical and policy experts today who will provide color commentary to the somewhat dry clinical and economic analyses we'll hear from Dr. Jeff Tice, Dr. Jim Kahn, and Dr. Dan Ohlendorf shortly. After lunch, we will consider our round tables, where we will consider broader contextual issues in the treatment of hepatitis C and how these types of drugs are going to impact the cost of healthcare in the country. And at the end of the day, we'll reflect and see if there are policy actions or issues we can highlight or bring to the public for further discussion. In the middle of the day, we will get to our voting questions, which is where our panel is put on the spot, and will ask to be asked to state on the basis of the evidence they've heard some very pointed questions of comparative effectiveness based on what Jeff and our clinical experts have told us. And you will see the panel voting. We will make known what the results of those votes are, and we will try to explain the thinking that went into that, both during the discussion today and in our final report. Lastly, it should be noted that a number of parties have submitted public comments which appear on the CTAF website. We are reading those, and we'll be responding to those in our final report and look forward to the public comments and input that we'll hear today. So with that, I'd like to invite Dr. Jeff Tice up to the podium to begin the clinical evidence review.
Thanks, Dr. Weisberg. And I'm Jeff Tice. I'm going to present the evidence review. I have no conflicts of interest. And I just wanted to start with a little bit of history because you just get a sense of the remarkable progress we've made when we look at when the FDA approved pegylated interferon plus ribavirin for the treatment of hepatitis C, which was a real advance. It was better tolerated and less frequent injections, but still we all know the problems with the old treatment of pegylated interferon and ribavirin. That was in 2001. It wasn't until 2011 that we had our first drugs directly targeted at the hepatitis C virus itself, boceprevir and telaprevir. And then in a short 2 years later, we had the drugs that we considered in March, cimeprevir and sofosbuvir, so second generation direct-acting antiviral medicines. And a short year later now, we're talking about interferon-free combinations of 2 or more of these direct-acting antiviral therapies. The primary outcomes that we're going to consider are really an intermediate outcome, sustained virologic response. For an infectious disease like this, that should be a good intermediate outcome. It really should reflect cure, though as we know from data from long-term follow-ups, the sustained virologic response at 4 weeks after the end of therapy is higher than that at 12 weeks, which again is higher than that at 24 weeks and higher than if we follow out for a couple of years. So it's not a perfect measure of cure, particularly the SVR12, which is now the standard that the FDA uses for evaluating the drugs and that all the newer studies use as the outcome, the primary outcome when evaluating the new drugs. Really, we'd like to have studies that look at really important patient outcomes like the development of cirrhosis, hepatocellular carcinoma, and decompensation of liver disease and death. But as Dr. Weisberg highlighted, the natural history of hepatitis C is slow. Those studies would take years, and clearly we have so many new therapies that offer many advantages. We've decided, and the FDA has decided, to approve therapies based on this intermediate marker, which again seems reasonable. So the single DAA regimens, I put up the FDA indications here just to highlight cimeprevir for 12 weeks plus an additional 12 weeks of interferon for the majority of patients, an additional 36 weeks, so more like the total 48-week therapy that we used to do for pegylated interferon and ribavirin for patients who had been previously treated and were partial or non-responders, so never had a complete response. Sofosbuvir is approved with pegylated interferon and ribavirin for 12 weeks, and if they're interferon intolerant, for 24 weeks with ribavirin alone. So these were the new FDA approved medicines that medicine combinations that we considered at our last meeting, and will really be in some ways the comparator group for the new therapies we're considering today. They had reasonable SVRs, depending on the study and the patient population group, between 55 and 92%, which was better than, or equivalent to, or better than the first-generation DAA therapies, the pegylated interferon plus ribavirin plus either boceprevir or telaprevir. But they still, many patients cannot tolerate them or have contraindications, and mainly because of the interferon. And interferon has many side effects, as everyone's aware in this room, with fatigue, fever, anemia, depression, and anxiety. That makes it a very difficult therapy for patients to tolerate, especially since therapy is generally required for almost a year with interferon alone, and still up to 48 weeks with single DAAs. So the new therapies to be considered today are two FDA-approved combination therapies, dual DAA therapies, Harvoni, which is ledipasvir plus sofosbuvir. We're mostly going to call it LedSoft today to make it a little easier to say. And that's indicated for 12 weeks for treatment-naive patients. And if their viral load is relatively low, less than 6 million international units per milliliter, then the FDA says it's reasonable to consider only 8 weeks of therapy. And there are not great published data yet on the epidemiology of patients available for treatment who are treatment naive in terms of the 6 million international unit per milliliter threshold. We've used some data that suggests it's around 2/3 of patients, 67%, but there are some studies where a higher proportion of patients qualify, others where a lower proportion of patients qualify. So we still, that's one area where we'll need more data. And I think this is important because clearly this, when we come to the economic analyses, this determines the cost of the net cost of the therapy. If patients are treatment experienced, then they require, the FDA recommends 24 weeks of therapy. Cimeprevir plus sofosbuvir, a combination considered a little bit based on unpublished data before. Now the Cosmos trial has been published, and the FDA approved this combination for 12 weeks if there's no cirrhosis and 24 weeks if there is cirrhosis. There are also two additional multiple DAA therapies that we considered in the draft evaluation. One, decladisvir plus sofosbuvir. It was thought that it may be approved by the time of this meeting. The FDA actually requested additional data, so they've deferred approval on, or a final decision on this combination, but there are data in the draft report on this combination, and also the combination known often as 3D because it has 3 direct-acting antivirals, paritaprevir plus ritonavir, co-formulated in one pill with bidosvir and dasapuvir, with or without ribavirin. Most of the larger phase 3 studies included ribavirin, and we focused on that in most of our tables and presentations. The FDA decision may come down tomorrow on that. We thought it might happen before this meeting, which is why we included it. We wanted to be as relevant as possible, as up-to-date as possible for the discussion today. So with that, I'm going to turn to the evidence review. I wanted to give you a background, a little bit about why we chose the different regimens that we looked at. We're going to focus on 4 specific subgroups, as you saw from the FDA indications for the medicines. It's often based on whether or not a patient has been treated before, so treatment-naive patients, never treated, treatment experienced, treated with something, either pegylated interferon plus ribavirin or that combination plus first-generation DAA like boceprevir or telaprevir, and then whether or not a patient has cirrhosis or not. Patients with cirrhosis generally are harder to treat, require either longer therapy or additional medicines to achieve equivalent SVRs. We performed a systematic review. We used a research librarian who spends her career doing systematic reviews. We also reviewed all the published reviews of the newer therapies for treating hepatitis C. We contacted the manufacturers and local experts to make sure we identified all of the literature. We focused on phase 2 and 3 data for the FDA-approved dosing, though other dosing regimens were included for completeness in the report. And usually CTAF requires published data in order to evaluate data. The one exception in the past has been the inclusion of data from manuscripts that have been accepted for publication, and the editors of the journal and the authors allow us to use the data. In this case, again, to be as up-to-date and timely as possible, we did allow the use of abstracts, but I will say I think only 2 of the studies, and both are phase 2 studies, actually pulled data from abstracts. All of the other trial data came from the published literature. All of the phase 3 trials have now been published from the data that we're considering today. We did a meta-analysis within each of the 4 subgroups. For those who were at the prior meeting, we're able to do a network meta-analysis. So it's not a perfect meta-analysis, but it's a way if different treatments have a common comparator group, they were all compared to pegylated interferon plus ribavirin, or all compared to placebo group, then we can use sort of indirect methods to make essentially a comparison directly between the different regimens. For all of these new DAA regimens, there are no comparator groups. Many of the trials were randomized trials, but there was the randomization was to different durations of therapy or different combinations of therapy or different doses. And there were no common comparators, no comparison to any other standard therapy. So we were unable to do a network meta-analysis this time. We just did a meta-analysis of the proportion who achieved SVR, the proportion who were unable to complete therapy. And those are the SVR12s that we'll report and the discontinuation rates that are in the report. And just maybe a little more detail than most want, but sometimes our numbers don't match exactly what's reported by the manufacturers, and that's because we were fairly strict in our interpretation. If a patient was randomized and then excluded for some other reason, because they never took a pill or something, we still included them in the results. If the decision was made to initiate therapy, even if the patient didn't initiate therapy, we considered those a treatment, essentially a treatment failure. In many of the published papers, those patients were excluded from the calculation of the SVR12. So we were a little more strict than some of the reported results of trials. Similarly, for discontinuation rates, these aren't just the discontinuation rates because of adverse events. We also included in the denominator, we considered patients in the numerator and the denominator, patients who were lost to follow-up, patients who decided they didn't want to participate in the study anymore and withdrew consent. So we were fairly strict in our interpretation. So now we're going to turn to the results. We're going to look at those 4 groups again. And these data are the sustained virologic response at 12 weeks in most cases for each of those 4 subgroups. There are going to be 4 figures like this, and hopefully, yeah, I'll try and orient you a little bit. The height of each of the bars represents the SVR12, so the percentage of patients who achieved a complete virologic response 12 weeks after the end of therapy. The first 3 bars are the single DAA regimens, the ones we considered before with either just cimeprevir or sofosbuvir plus interferon and or ribavirin. The next 4 bars are the new therapies. And this first graph represents patients, in addition to the height of the bars, I should say there, you'll see some little dark lines, vertical lines. Those are the 95% confidence intervals. And it's particularly important in this case when you look at, sorry about that, this is not going to work too well. Go back one more time here. The cimeprevir plus sofosbuvir regimen. The 4th bar, you see that vertical line is very big. There's a large 95% confidence interval, and that reflects the very, very few numbers. I think there were 4 patients in this subgroup of treatment-naive, non-cirrhotic patients who received the FDA-indicated therapy for genotype 1 in the Cosmos trial. So very little data, hence a wide confidence interval. But one of the common themes through all 4 of these slides, as you'll see, is that the newer regimens have very high SVR12s. They all are between 90 and 100%. Most are very, very close to 100%. And they aren't very different. Certainly the confidence intervals overlap. And in general, they are higher than the older regimens. So this was the treatment-naive non-cirrhotic patients. With cirrhotic patients here, there are smaller numbers in all of the subgroups. So you see the confidence intervals are much broader. Those vertical lines are much longer this time. But the general theme of the newer DAA therapies being better and being more or less indistinguishable when you consider the uncertainty holds for treatment-naive cirrhotic patients. When we move to treatment-experienced patients, actually there are no published data from phase 2 or phase 3 trials for the sofosbuvir containing regimens, so we just included the cimeprevir containing regimens. One of the pieces of feedback we received, comments on the data, highlighted the fact that we actually used the data for all patients with genotype 1 treated with this regimen, In truth, the FDA indication for Cimeprevir plus pegylated interferon and ribavirin restricts it to patients who do not have a particular mutation which makes them less responsive to Cimeprevir. And so if you look at that restricted group, the SVR12 is actually higher, but we're trying to give an overall comparison for all patients with genotype 1 infections, which is why we presented the data this way. But just so you're aware of our rationale for doing it the way we do, in a subgroup of patients with genotype 1 who don't have a mutation that makes them less responsive to Cimeprevir, the SVR12 is somewhat higher. But again, for all 4 of the new regimens, the multiple DAA regimens, the SVR12s, even in these cirrhotic patients who are treatment experienced, excuse me, these are non-cirrhotic patients, but non-cirrhotic patients who have already been treated in the past and failed treatment, we're at 95 to 100% cure rate. So a remarkable improvement for simpler regimens without interferon. And finally, the treatment experienced cirrhotic patients, again, the same story, a remarkable cure rate, but broad confidence intervals, so relatively small numbers of patients treated here. The harms of treatment, I think this really gets at the use of interferon. So the first couple of regimens, sorry, it's a little hard to get from this angle, but you see that the flu-like symptoms, the myalgias, fever, and so on that are seen with interferon, you see are relatively common in the first 2 columns, the Cimeprevir and sofosbuvir-based regimens, the single DAA regimens that require interferon and ribavirin. So 15 to 25% of patients experience those symptoms. When you take away the interferon, the third bar, sofosbuvir plus ribavirin alone, it goes down to 3%. And in all the new regimens, it's very low, below their threshold for reporting common side effects. And in the case of the combination of cladosphere plus sofosbuvir in that study, nobody had that symptom. Anemia also drops off dramatically. So anemia is a problem with interferon, but particularly ribavirin plus interferon. And you see it's relatively common, 10 to 20% in the first 2 regimens. When you have 24 weeks of a ribavirin alone containing regimen, it's still very common, 9%. But without ribavirin, so the first 3 of the DAA regimens, there were no patients who had a hemoglobin level less than 10, which was the commonly reported threshold for reporting anemia in these studies. For the 3D regimen that included ribavirin, you again see a small number at 12 weeks, and for the regimens that went out to 24 weeks, you again see more anemia. It's known that ribavirin causes a hemolytic anemia. So those were the big differences. There are also more rashes with Cimeprevir in particular. That causes a known photosensitivity reaction, and the earlier regimens all have more rashes than the newer regimens. I should say, I didn't include it in this table, but significant adverse events were very low in all 6 of these groups. They were a tiny bit higher, 1 to 3% in the single DAA regimens and 0 to 1% in the newer dual and triple DAA regimens. Similarly, discontinuation rates due to adverse events were very, very low, on the order of 2 or 3% in the single DAA regimens and mostly 0% in the newer regimens. So there are a number of limitations, I think, with the data. As I alluded to earlier, there are no direct comparisons either between the new regimens or between the new regimens and single DAA therapy, or even pegylated interferon and ribavirin together. And that is a real weakness in terms of really trying to do comparative effectiveness of these different regimens. So we're comparing different groups by breaking it up into the 4 subgroups that we've done. We've tried to eliminate some of the major sources of potential selection bias, but it still may be that some of the drugs were examined in groups of patients that were less likely to achieve SVR because they had genetic characteristics that predisposed them to poor response or whatever. We're really unable to assess that adequately with the level of data, and that's a real weakness here. We've used an intermediate outcome, SVR12. So we don't really know long-term what's going to happen. We know from prior data from pegylated interferon and ribavirin, long-term follow-up, that clearly you have an impact on important clinical outcomes, but it's an imperfect measure. We'd really like to have longer-term studies. And I just want to highlight that even though you may achieve a long-term suppression of the virus or eradication of the virus, some patients still have a residual risk for developing hepatocellular carcinoma. So patients with cirrhosis, still, even if they're cured, they still need to be monitored for hepatocellular carcinoma, and that is also true for the F3, sort of the stage of fibrosis just before cirrhosis. There's still some residual risk for hepatocellular carcinoma. And finally, the number of patients studied in the different treatment subgroups are really small in many cases. So there's a lot of uncertainty among some of the estimates. Some of the subgroups and treatment regimens have a large number of patients, and we're fairly confident about the results, but others were not. And finally, real-world results. In all of the literature of the earlier regimens, patients in the real world, patients that are treated outside of clinical trials, always have lower SVR 12 and 24 rates than those reported in the randomized trials. That's in part because randomized trials are all about proving efficacy, and so the investigators do a really good job of picking out patients who are likely to continue to be in the study, to take the therapy despite some side effects. And often they have staff that's really skilled in supporting patients through the side effects and just encouraging patients to continue. That tends to not happen quite as effectively in the real world. So almost always the SVR12s are lower in real world studies. We have a little bit of data that just came out at the AASLD, which was reported in many of the comments. And again, consistently we see lower SVR12 rates. Exactly how that will pan out remains to be seen. So we certainly need additional studies. We'd really like randomized trials comparing these new therapies. Thankfully, PCORI just came out this week or last week with a big request for proposals to do just this. They have $50 million set aside to study randomized trials comparing these new therapies. So there's actually a funding mechanism. So we probably will get some of this done. Large, well-done observational studies will give us the real-world SVR rates, will help us. Comparing therapies, though, will never be as sure as if we have randomized trials. Will help us identify uncommon adverse events. Again, we only have a couple of hundred patients treated with some of these regimens, so we really need more data to identify uncommon, potentially serious adverse events that were not identified in the trials, and also just to have more precise measures of the incidence of adverse events. We can certainly get that from large, well-done observational trials, and there are a number of those underway. And again, the PCORI wants to fund some of those as well. There are also important subpopulations and underrepresented populations where we need more data. In the full document, we talked about some of the data on co-infection with HIV, co-infection with hepatitis B. More studies have come out since the report, and that's an important subgroup that all of the manufacturers are sponsoring studies in those subgroups because co-infection is a real problem. There's also been another important subgroup are the sickest patients. For the most part, patients with decompensated liver failure have been excluded from these trials. And so and there are now some data coming out in that subgroup, but we need more data, and also more data around patients who are either about to undergo transplant or have just undergone transplant in terms of preventing infection in the transplanted organ. And finally, subgroups that are often underrepresented, African Americans traditionally have had a lower response rate to interferon-based regimens. The initial data suggest comparable response rates, but really they're underrepresented in the trials. We don't have enough numbers yet to really say that with full confidence. Older Americans, and that's an important, as the aging baby boomers, I'm a baby boomer, many of them have not been well represented in the trials to date. the older adults. So we need more data there. And as is highlighted by folks outside today, injection drug users are an important population. There's a high prevalence of disease in that population group. They're the major source for ongoing new infections. And if we're going to have an impact on preventing new infections, this is an important group to target. There's a lot of research in treating active injection drug users who are co-infected with HIV, and I think the same groups can do similar kinds of treatment for studies for hepatitis C, and hopefully help us sort out the best ways to treat this important subgroup as well. I just wanted to briefly highlight some of the comments. Bristol Myers Squibb wanted to highlight that they think we should focus more on the treatment regimens with ribavirin. It was a judgment made for the regimens that were not yet FDA approved. We made a guess about what we thought would be the approved regimen for the combination of sofosbuvir and simipravir. We were wrong, so we've updated some of the data for the, particularly for the cost analyses that you'll see going forward. We're sort of waiting for the FDA regimens to FDA approval to really know what we should focus on. For declatosphere, for acinepravir, that was removed. The FDA application was removed by the company, but the company wanted to highlight that declatosphere, that application is still with the FDA. Project Inform wanted to highlight that we didn't really talk about the quality of life outcomes in the clinical review, which is true. We thought the clinical evidence was impressive enough without that, and focused on including that in the cost effectiveness and cost analyses. But they were concerned about that. Janssen highlighted the issue of the Q80K polymorphism patients, that those patients do not have a good response to simipravir and should be excluded from the numbers. And they also highlighted that there's a big phase 3 trial that will have results in 2015, which will answer some of the issues about limited numbers for this combination. Gilead highlighted that one of the studies that we had has new results at AASLD, and that some of the numbers we used for patients with cirrhosis treated with lead-soft from the Electron 2 trial shouldn't really be included because they had decompensated cirrhosis, and those patients are more difficult to treat, so we underestimated the SVR by including that group. They also wanted to highlight a new study presented at AASLD of lead-soft with ribavirin for patients who were treatment experienced and had cirrhosis. That group thus would have a shorter therapy, 12 versus 24 weeks, which is the FDA indication, and they had high SVRs in this study. And then AbbVie highlighted some of the new data on real-world efficacy presented at AASLD, and one of their trials in patients who are co-infected with HIV, the CORAL trial, which has now been published in the New England Journal, but after our review was written. So there's some new data, but it really doesn't materially change what we've presented today. So in summary, for the clinical effectiveness piece, there's no question, I think, or there's a moderate certainty that the multiple DAA therapies are more effective than the single DAA therapies for two main reasons. One, the SVR12s are greater and often substantially greater, but more importantly, they're easier to take, they have fewer side effects, they're shorter therapies, and so the combination of better effectiveness, fewer side effects leads to net benefit compared to single DAA therapy, which requires pegylated interferon and ribavirin. However, there's still a lot of uncertainty about the true estimates of SVR12 because there are no direct comparisons and there are small sample sizes within many of the subgroups. And when you're comparing the 4 new regimens, we really feel like there's insufficient evidence to distinguish them. The confidence intervals overlap substantially, and there are no direct comparisons. One may be better than another, but we can't really tell from the presented data to date, and again, small subgroups. So with that, I'm going to turn it over to Dr. Khan to do the cost analysis. I think we're going to hold questions until all of us have spoken. Is that correct?
Yes.
Okay. Thank you for your attention.
at a distinct disadvantage. I actually can barely see the slides, and there's no monitor, so I'm going to move this. I'm going to improvise. I'm going to join you in the audience.
Do you want a paper copy?
Paper copy. No, this will be okay.
Okay.
Thank you very much. So I am happy to be presenting on the care value analysis or cost effectiveness analysis. This is work that I did with colleagues Harinder Chahal and Elliot Marseille. I want to particularly credit Harinder with the actual modeling. And I also want to emphasize that this is work done closely in collaboration with ICER, and they probably should be listed here as well. Oops, that would be the wrong direction. I have no conflict of interest. The research questions that we looked at are, what are the outcomes and costs of the newer treatment regimens when compared with the previous interferon and ribavirin therapy? And that's where our focus is in this presentation today, and also when compared with each other, as seen in the report. And then, what are the relative costs and health gains of waiting until patients reach more advanced disease, fibrosis stages F3 and F4, versus treating everyone in a prevalent cohort of all fibrosis stages F0 to F4. For our inputs, we modeled the US population, 60 years old, which is the biggest group with HCV, and looked at the prevalent mix of fibrosis stages. We used an all-payer perspective looking at direct medical care costs, including drug costs. We looked over a lifetime, so until individuals die. We looked at the hepatitis C natural course without treatment or with treatment failure, and then we compared that with the course after successful treatment. Under costs, we looked at drugs, ongoing HCV care, including HCV complications. We looked also at quality of life using health state utilities, which is a quantitative measure of that. And for efficacy, we relied on the ICER systematic review, which Jeff just presented. This is a simplified model, a simplified structure of the model. We started, as you can see here, with individuals with known CHC infection. We then, as I mentioned, we portrayed the progression through the disease stages. This is just a partial tree, but you can see that for any disease stage which we might model, we compared what would happen with one regimen versus another. We took into consideration, first off, the likelihood of getting 8 or 12-week therapy. We looked at the probabilities of achieving SPR and so on. Anyone who's interested in the fully articulated model would be happy to share that. For our outcomes, we looked at cost of the drug treatment itself, as well as costs from complications and sequelae, including, for example, hepatocellular carcinoma and other ongoing HCV-related care, monitoring, treatment of extrahepatic manifestations, and so on. We looked, importantly, at quality-adjusted life years, or QALYs. QALYs combine the effects of reduced mortality and extended years of life, along with the effects of reduced morbidity. We then looked at the incremental cost-effectiveness ratio. This is the difference in costs between two treatment strategies, or between treatment and no treatment, divided by the difference in QALYs. One way to think about this is the ICER tells you the price of gaining a QALY when you move from less to more expensive treatment options. Here are our results for treatment-naive populations. As you can see where we've highlighted in green, LEDSOF here, these are all compared to the PR regimen. LEDSOF has an additional cost compared to PR of about $28,500. And for that, there's a gain of about 1.4 QALYs. So when you do the calculation, that means the incremental cost-effectiveness ratio is about $20,000 per added QALY. In other words, it costs about $20,000 to add per added healthy year of life. If you look at the other regimens, they're a little bit higher. Again, all compared versus PR. You'll note that for many of the regimens, the difference in effect is quite small. They're all in the 1.4 to 1.5 range. And as Jeff pointed out, the confidence intervals on the efficacy are quite wide. And we can't really say much about the difference in efficacy. So the differences here mainly reflect differences in prices. For treating later in disease, the cost-effectiveness ratio is a little bit better. If you treat later, you get more clinical benefit with less added cost. And so instead of $20,000 per ICER here, it's about $16,000 per ICER there. Also, note that we do not include declatosphere and 3DR. These have similar benefits to these regimens, but we could not find price data at this time, and so we didn't include them. By way of comparison, it's widely accepted that the threshold for being cost-effective in the United States is somewhere between $50,000 and $150,000 per quality gain. So by that standard, $20,000 per quality gained is considered cost-effective or very cost-effective. We also looked at treatment experienced. Again, every regimen of the new regimens compared versus PR. And what you see here is that the cost-effectiveness ratios are a little bit more attractive. Here it's $17,500, here $9,400 per quality gained. And the reason for that is that PR doesn't work very well in treatment experienced patients. Of course, these are people who probably had PR, so doing it again doesn't work very well. As a result, the relative advantage of the new regimens is more pronounced. We did a sensitivity analysis, a one-way sensitivity analysis. This kind of diagram is called a tornado diagram for obvious visual reasons. And what this shows is that the most important uncertainty in our analysis was the cost of the treatment itself. And we assumed for these inputs roughly a 50% to 150% range from the best case number. So if the regimen is less expensive, you see down here, it actually means that there will be net savings at the 50% price, net savings. At the 150% level, the cost effectiveness goes to about $50,000. So as you recall, that's still underneath the threshold for what's considered cost effectiveness. Other uncertainties had a less important effect: the cost of the PR regimen, the percent eligible for 8 weeks of the ledepasvir-sibosavir regimen, and the PR discontinuation rate. And these others here had very little effect. We didn't list the names, but again, of course, all of this is available. If you put this all together, you get something that looks like this. We're comparing Let's-Off versus PR in treatment-naive populations, treating everyone. And what we did is we ran the model many times, tens of thousands of times, with grabbing randomly from the potential input values. So it's called a multivariate sensitivity analysis, and then presented the results this way. And what we see is that if you look at the threshold of $50,000, more than 95% of the simulations show the cost effectiveness was less than $50,000. So this is consistent with our primary result of about $20,000. But there's some uncertainty due to the input values, and so it's not always going to be $20,000, but 95% of the time it will be less than $50,000. We also compared treating all with treating at F3 and F4 only. In other words, what is the added benefit and added cost of treating earlier, treating everyone instead of waiting until people reach F3 or F4? And what we found for Let's-Off here is that treating earlier adds some cost, about $26,000. It also adds some clinical benefit, about 0.7 qualities. And the incremental cost-effectiveness ratio is about $35,000. So it's not as cost-effective as treatment overall, but what it says is treating, according to our analysis, treating earlier provides a clinical benefit at a cost per quality gain that is still below the threshold for what's considered cost effective. When we looked at the treatment experienced population, For the same regimen, it was just a bit over $50,000. And these numbers vary a little bit by regimen, although, as noted by Jeff, there's some uncertainty there having to do with uncertainty mainly in how well the regimens work. Why is this? Why are there more QALYs in the treat-all approach rather than waiting until F3, F4? There are two reasons. SVR improves the quality of life for patients with F0 to F2 fibrosis scores. So the quality of life component of QALYs goes up. In addition, SVR reduces mortality by reducing the number of patients who progress to F3. Importantly, if you treat and achieve SVR, it is not a complete cure. There are still, as Jeff mentioned, there are still risks of progression to later disease stage. There are still small but real increases in mortality compared to people without HCV. And so by treating early, you reduce the progression to F3 where some of those mortality risks reside. So if you look at both of these factors, depending on the regimen, about 2/3 of the benefit of early treatment is from the health status effect, and about 1/3 is from lower mortality. Limitations of the model include that we relied on clinical trial data, as Jeff noted, that may not represent real-world results, and we'll update these findings as we get more real-world results. We did not consider the reduction in transmission from successful therapy. That, of course, would improve the cost-effectiveness ratio. We didn't look at risk of reinfection with HCV or at SVR relapse, which would worsen the cost-effectiveness ratio. We didn't examine retreatment of patients who failed to achieve SVR. That is, we modeled only one course of treatment. And we did not look at people with co-infection with hepatitis B or HIV. In conclusion, under a wide range of values for price and effectiveness, the lead, SOF, and Cimeprovir cephosphopir regimens show cost-effectiveness ratios, or ICERs, that are below commonly accepted thresholds for attractive cost-effectiveness. The model also appears to show that treating everyone, rather than waiting until F3, F4, meets these commonly accepted cost-effectiveness thresholds. Thank you.
Thank you, Jeff and Jim. So Steve's told me I have to talk twice as fast, so I'm going to skip every other word if that's okay. Just kidding. So as a companion to the cost-effectiveness analyses that Jim just presented, we also conducted analyses that tried to analyze the expenditure impact from a health system perspective of the introduction of these new agents. And so we're terming that health system value analysis. So I have no conflicts of interest to disclose as well. So this analysis really took the form of three distinct components. The first was kind of an intermediate look at the model that Jim just discussed. So we looked at clinical outcomes and total costs at 1, 5, and 20 years following the initiation of treatment in a hypothetical cohort of 1,000 individuals. And so the outputs for this component of the analysis came directly from Jim's model. Oops, sorry. But we also looked at the budgetary impact, the one-year budgetary impact of the introduction not only of newer regimens for genotype 1, but also borrowing some data from our original analysis in March, the introduction of new therapies for genotypes 2 and 3 as well, to try to give a holistic view of the impact to a typical health system or payer of the introduction of agents for the 3 most common genotypes in the U.S. We extrapolated this analysis to the size of the Medi-Cal and Department of Corrections population in the state as a population of specific interest. And another thing that we did was to try to compare the budgetary impact that came out of this analysis to sort of a relevant benchmark for expenditure for a common service provided in the Medi-Cal system. We'll talk about that when we get to the results. And then finally, we also took a look at sort of separate and apart from the expenditure given assumptions around current prices, at what threshold of new expenditure would or given a threshold of new expenditure for a health system or payer, what would the price of a new intervention have to be and not exceed the threshold? So this is not a controversial topic at all. But we used a 0.5 to 1% PMPM budget impact threshold. PMPM stands for per member per month, a typical way to describe and explain the expenditures or premiums that are paid by a health insurer. And this is not a published standard. It is not a community standard in any way, but it is implicitly considered by some payers as the threshold at which a short-term budgetary impact, so over 1 year, of a single intervention often requires some policy effort to address the potentially negative effects of introducing such large costs into the system. And so that's the threshold we use. So let's move into the cohort analysis first. And for this analysis, we compared lead-soft to the historical standard of PR in a treatment-naive population using the treat-all framework that Jim just described. We did this because, as you saw from the results that Jim presented, lead-soft was the most effective FDA-approved new regimen, and in fact the most cost-effective FDA-approved new regimen. So we thought that was an appropriate standard to look at, and PR was the historical standard that was used throughout these analyses. I also want to mention this is a little bit of a segue or a non sequitur, but for both modeling efforts, we really want to acknowledge the assistance of Dr. Rena Fox, who you'll hear from later as a clinical expert in terms of helping us specify the model. So thank you, Rena. So again, a hypothetical cohort of 1,000 patients with HCV at the prevalent distribution of fibrosis stages, so all fibrosis stages, followed for 20 years. Compared to the historical standard of PR, lead-soft would prevent 150 cases of cirrhosis per 1,000. 55 of those would be decompensated cirrhosis, 20 cases of hepatocellular carcinoma per 1,000, and 3 liver transplants. So substantial clinical benefit here. One thing to keep in mind as a footnote is that because the model, and Jim described this in the limitations, because the model assumed a single course of treatment, these benefits are likely to be overstated somewhat because, in truth, patients failing PR would be retreated with some other regimen, probably one of the newer regimens, and so their clinical outcomes would be improved. On the flip side of that, we get to the cost, and so some of the differences in cost that I'll be showing are again based on that single course of treatment, and some of those differences would be mitigated if a lot of the PR patients got a more expensive, newer regimen after failing PR. But to take a look at the cost impact over 1, 5, and 20 years, you see here that 1 and 5 years, essentially the differences are about the same. These really reflect the difference in treatment costs, the prices of the drugs themselves. But at 20 years, you begin to see the impact of those cost offsets from reduced rates of serious liver-related complications. And so the difference is diminished, and about 25% of that difference is offset by reductions in the rates of transplants, hepatocellular carcinoma, etc. So let's move on to the second component, the budgetary impact to Medi-Cal and corrections. There are 2 key assumptions that we feel may have had some countervailing effects here, and one of which is that the candidate population for our analysis came from a separate source of data suggesting that there were 93,000 patients with chronic HCV in the Medi-Cal and corrections system. We've heard from others, and we've seen other unpublished estimates suggesting that this number is actually much higher because the prevalence of HCV in these 2 populations is higher than in the general population. We also assume that 50% of infected individuals were aware of infection and would be treated. We have heard from others that this percentage is actually much lower. But again, if our starting point in terms of denominator is also much lower, there are some countervailing effects to consider there. The most effective new therapies across the 3 genotypes were again lead-soft for genotype 1, as well as sofosbuvir plus ribavirin for genotypes 2 and 3, 12 weeks of that regimen for genotype 2, 24 weeks for genotype 3. And we presented this as increased treatment costs or expenditures over 1 year, as is typical with budgetary impact analysis. We also, for additional context, produced population-based estimates of those offsets at 5 and 20 years as well. And we compared this to the historical costs of PR. We weighted that cost for the percentage of the population expected to be eligible for interferon-containing therapy, and that's about 60%. So the historical standard cost of PR was about $25,000 per patient. So as you see here, in the green bars, you're looking at that one-year budgetary impact. Am I actually showing anything? I guess not. Oh. There we go. Okay. All right, I'm not going to worry about it. So the green bar represents the new expenditures associated with the drugs themselves, and then the red and purplish bars relate to the offsets at 5 and 20 years, respectively. What we're seeing all told, with all genotypes combined together, is about a $3 billion expected impact to the Medi-Cal and corrections population in the state. A small percentage of those costs are offset at 5 years, a much greater percentage at 20 years, but we're still looking at a $2 billion impact. And so what does that translate to in terms of PMPM? Okay. Now this is, oh, there we go. Wait a minute. Sorry. I have no idea what just happened here. I was hitting the same buttons, I promise. All right. Is there a way that we can get the presentation? Okay. That's not my presentation.
Oh, wow.
Oh, jump.
Okay. So can we blame this on North Korea too? That's the problem.
I love it. I love it.
Okay. Great. Thank you. Okay, so we're in good shape now. All right. So to put this in terms of the PMPM estimates I talked about, that $3 billion increased expenditure is about $33 per member per month. We saw an estimate of the Medi-Cal PMPM, the base PMPM that's current for 2014, of $611. So that $33 increase per member per month represents about a 5% increase in the PMPM. And again, the threshold benchmark for discussion is 0.5 to 1%. So a big difference there. And again, just to put that common service into some context, the approximate Medi-Cal payment for well child visits in an established patient is about $44 per visit. So that $3 billion represents about 70 million well child visits, or about 18 visits for each of the 3.9 million children currently enrolled in Medi-Cal. So a significant expenditure, one that would have to be managed in a big way. So in contrast to the total population analysis, we also did a budget impact analysis, as we did back in March, focused only on those patients with prevalent F3 or F4 fibrosis stage. And here you see that the budgetary impact is much less pronounced. It's about $800 million over 1 year, as opposed to $3 billion. And again, the offsets play along with that as well. And I was going to talk about this when we got to the comments received. I'll reiterate it then. But I think one of the comments that we got was about how, while these data may not be available publicly, our estimate of drug prices in both analyses was overstated. Medi-Cal receives both mandated and supplemental rebates from manufacturers for innovative drugs. The Department of Corrections also pays much lower than the list price for drugs. Again, we didn't know what the true prices were, so we went with what was published, average wholesale prices. But we did conduct an analysis assuming a straight 23% discount, that is the federal mandate, in terms of a rebate for innovative drugs to Medicaid, and found that that $3 billion impact declined to $2.3 billion. The PMPM impact declined from $33 to $25 PMPM. That is still a 4% increase in the PMPM rather than a 5%. That will be reflected in the final report. So then finally, the third component is our policy threshold discussion. And again, using that 0.5 to 1% range as the threshold. We assumed, again, that base Medi-Cal PMPM of $611, so that you're talking about a $3 to $6 increase in the PMPM to be within that threshold. We based on that 93,000 estimate for those infected with HCV, we assumed that 65,000 of those would have genotype 1 based on published prevalence data, and 50% of the 65,000 would be aware of their infection and treated, so about 33,000 total. That was our number of affected patients. And so using those assumptions, the cost of any new intervention that would be below this range of threshold, 0.5 to 1%, would be $34,000 to $42,000 per patient. So we then took that and looked at it from a little bit of a different angle to say that is the sort of the price that would meet the threshold without relation to any particular regimen. So we said at current prices, again, using average wholesale price as a starting point, for lead-soft, the number of patients that could be treated with that 8-week or 12-week regimen, if the expenditure increases were held at these thresholds, were about 50 to 65%, respectively, depending on the threshold. So if there were no other sort of clinical prioritization criteria put in place, and it was just, we need to stay under this threshold, how many of the patients who would present for treatment could we actually treat? It's somewhere between half to 2/3. However, if some sort of clinical prioritization took place, F3, F4 as one example, all patients could be treated at current prices and remain under the 1% threshold, and almost all patients could be treated and remain under the 0.5% threshold. So let's talk a little bit about comments. I sort of alluded to some of these already. About 50% of patients with known infection were estimated in our models to present for treatment. We heard from many that this was too high. We heard from at least one commenter that this was actually too low, that in fact, with recommendations for screening of the baby boomer population, the overall number should go up and awareness would actually go up as well. So we got comments from both angles. Again, we heard that drug prices didn't take into account mandated or supplemental rebates, and we tried to address that in the results I just described, and those will be reflected in the final report. We also got some comments directed at the cost effectiveness estimates that costs of complications and ongoing care for hepatitis C were underestimated. Again, we obtained those costs from published sources, and with any model, any commenter may have a particular issue with a particular estimate. That's why models are what they are, and that's why we try to make them as transparent as possible. We did hear from several that models that we used did not consider the benefits of treatment as prevention. So taking a public health system perspective to say, if you do something on a population basis to help eradicate HCV, what kinds of savings does that provide to the health system? As all of us in the room are aware, there has not been that level of coordination around hepatitis C across public health agencies and payers and clinicians. So we felt that as a companion to the effectiveness data that Jeff presented, we were best served by looking at the economic impact of these regimens in comparison to each other. There was some discussion about more clarity needed around the Medi-Cal PMPM calculation, as well as the rationale for the 0.5 to 1% threshold. And again, there's nothing we can point to that's published on the threshold. We've heard this in conversation with a variety of payers and pharmacy benefit managers, but it really is something that is more suited to the discussion that will ensue later on today than to anything else. And then finally, there were some comments that the incremental cost and budget impact should be compared to the new standard of care. That new standard of care being described as sibosbuvir plus PR or simepivir plus sibosbuvir. We feel that the value conversation, especially from the health system perspective, is still an ongoing one. It is not without controversy, and so to accept on its face that the new expenditures that occurred last year are acceptable as a new standard, we didn't feel was appropriate. And in summary, So Leadsoft and the other potential interferon-free drug regimens, as you've heard, provide substantial clinical benefits over historical treatment, but this comes at a very significant short-term budgetary impact to both the payer systems we used in our analysis as well as any other payer. We did show that the prioritization approach that we highlighted back in our March report, when used here again, would allow for treatment of all or almost all patients at current prices while remaining below the threshold. And finally, using that threshold, the price of a new drug for HCV or any other condition for that matter, that would allow treatment of all infected individuals with known infection without exceeding that threshold would be about 34 to 42,000. Thank you.
Okay, the next part of the agenda is for the panel. Prior to voting, this is our opportunity to ask. I thought that was next after we. This is moderating the questions, and then we have public comment.
Public comments.
Okay. So the panelists can now ask questions of Drs. Tice, Kahn, and Ohlendorf about their presentations. Yes, Alex.
Hi, thank you very much. I have a question for Dr. Kahn. Jeff Tice mentioned that the real-world effectiveness of the newest treatments are unknown and are very likely to be lower than that found in the clinical trials. And I'm wondering how the sensitivity analysis captured that potential variation in real-world clinical effectiveness.
That's a great question. I do not have those numbers available right at hand, but I will look them up when we have a chance. Sorry for that.
Thanks.
Doug.
So I have a question for Jeff, if he's going to ask. So Jeff, this has to do with the little 4x2x2 table that you looked at, where you look in cirrhotic, non-cirrhotic, and treatment naive and treatment experienced. First of all, the question about how is treatment naive or treatment experienced defined? Are those people that took the treatment but actually did not have an SVR? Does that include people that didn't tolerate it?
So it includes a broad range of patients, from patients
including people who didn't tolerate it.
who did not tolerate it, patients who, yes.
So among the people who actually completed the previous regimen, these numbers could be different, actually.
They could, yes.
Okay. And the second question has to do with cirrhotic versus non-cirrhotic, because I think cirrhotic is just F4. And I think all the modeling, if I understand correctly, included F3 plus F4. And the question is, how did that matter?
The model takes into account the different SVRs by fibrosis stage, so that model actually has it has more granularity. F0, looks at F0 patients, F1 patients, and so on, and the appropriate SVRs within each of those subgroups.
Okay, so would this figure look much different instead of saying cirrhotic if you just changed it to F3 plus F4? I guess that was my.
Yeah. It might, but that would include, there are differences in response rates. So most of the time the data are broken out by cirrhosis, no cirrhosis in terms of the response rate, and also the recommended length of therapy and whether or not ribavirin is included and so on. Really depends on whether or not somebody has full cirrhosis. And so the clinical data are always broken out, or generally broken out, F4 versus all other F stages. And in fact, many of the clinical trials either were specifically within patients with fibrosis or within patients who did not have fibrosis. So that's often the way the numbers are presented in the trials.
I have a question for Dr. Kahn. Clarify this for me. Your costs were incremental costs above pegylated interferon and ribavirin, which has a substantial baseline cost. If you were to take the total cost of treating patients without taking the incremental costs above the PR, that would give us a little better idea, it seems to me, of the total cost of managing these patients. What is your comment about that?
So I think, if I can put it slightly differently, if we compared treatments to no treatment, is that your question?
That is my question.
Yeah, then indeed the incremental, well, it depends a little bit. Sometimes the PR regimen actually, in certain situations, is less expensive than not treating people, and sometimes it's more expensive because it's inexpensive enough, and it has obviously some efficacy that it can actually be cheaper than not treating people. But in direct answer to your question, in general, when we compared the regimens to no treatment, the cost-effectiveness ratios looked quite similar to what you saw, and we can make those available.
All right, thank you. Other questions? Jerry, you had
I'll just highlight for Dan that they are in the report. The no treatment comparisons are in the report.
Thank you.
Just a question that I'm imagining might be on the minds of many here today, either for Dr. Kahn or Dr. Ohlendorf. The language of currently accepted, commonly accepted, and so forth, when you talk about thresholds, seems sort of crucially important when you're going to play out the actual decisions about policy. So let's just take the 0.5% to 1% threshold that featured much in your talk. Commonly accepted by whom, and how do you find that out? And you know, it seems to me that bears a little more comment.
Right. Well, and this really, we've tried to be as transparent about this as possible, recognizing that it's not the most transparent thing, because again, there's no reference for us to look at. There are more references on the cost effectiveness side to commonly accepted thresholds. We really reached out to a variety of payers and pharmacy benefit managers to say, can you tell us generally at what point in terms of dealing with a new expenditure for a single agent, you would have to think about some major policy shift in either restricting access to other services or freeing up money elsewhere to try to pay for this new intervention. And so we heard from those on the private side that it was closer to 1%. We heard from those on the public side that it was closer to 0.5%. And so we used the range for discussion purposes. But I think we've tried to characterize this in many ways as a thought experiment, because we know that there isn't some sort of commonly accepted standard out there. The U.S. is not like other countries that do have certain thresholds that are publicly available for making those kinds of decisions.
Well, just to comment back and then see what any of the three of you might want to say back. Because I can imagine that most people, when they hear 0.5% or 1%, are thinking, gee whiz, that seems like a very small number. But then one has to think about the next 50 or 100 new treatments at the same kind of rate and where that would take us. So to some extent, it's that willingness to think systemically about what's happening. And for that, I suppose that one of the key slides was just the comparison with what that would mean for the treatment of a very large number of children, for example.
Right.
So I just want to say that, because I think when you start talking about, Dan said initially, well, let's talk about it. Our mission is to have a more effective, more efficient, and a more just, I'll just use what the 6-year-old would say, a more fair system. Yeah. And fairness gets into who reaps the benefits and who bears the burdens. And is that arrangement fair? And I would just encourage all of us to not think of the 0.5% or the 1%, but how that plays out in the world when you have the real world trade-offs. Because I think that slide is one that begins to get at that, which is the tough work that we're here to do today. That's a long statement, but I'm just looking to see if you're going to disagree with me.
Comments, gentlemen? Responses?
I completely agree. And in regards to the threshold for cost effectiveness of 50,000 to 150,000, there are actually a number of sources there, sort of consensus in the field, historical values that were used in U.S. legislation and the World Health Organization. That said, the threshold approach has real problems, and I think the kinds of perspective that you just articulated is ultimately extremely relevant, perhaps more relevant than any numerical threshold.
Yes, Marge.
Is this on? Yeah.
So clearly there's an argument for treating everybody who's an IV drug abuser because they're the ones most commonly now who are passing this on. So if they're treated, but they are continuing to abuse drugs, is there any data available about reinfection rates and how that would impact the cost of this?
There, again, because this, we focused attention on using the data available from the clinical trials in the modeling efforts. This is a population that has unfortunately been understudied in terms of the effects of these new regimens. I think there certainly is a risk of retransmission and reinfection in an IV drug user. I don't know the literature well enough to know exactly what that likelihood is.
Yeah, I don't know the exact numbers. There may be, maybe when our experts come up, there may be some who know the studies better. I know the risk of reinfection is relatively low. There are some data about that from the older literature. There is hope that this would be an effective way to eradicate the virus from the population if we can deliver the therapy effectively. And as I noted, there are certainly models for HIV care where they've been able to deliver even more complex therapies effectively to patients who are actively using injection drugs. So there is hope that we can do this effectively from a systems perspective.
Kimberly.
Can I just add one quick comment, and that is, if you have an ambitious program to treat injecting drug users, the more successful you are at treating them, the less likely they are at risk of reinfection.
Get them all.
So if I missed this, I'm sorry, but we talked about the discontinuation rate. Is there a downside to noncompliance? It's that there's increased resistance after being exposed to these drugs?
Yeah. Again, the experts may want to comment more, but one of the remarkable things about these newer drugs, particularly in combination, there's been very little development of resistance. There was one trial that I think was published after where the very most difficult patients to treat who were originally treated with a sofosbuvir-containing regimen were retreated with lidipizledzoff. And almost all of them, maybe actually 100% of them, were cured. So even in a group that were treated with sofosbuvir and had characteristics that made them difficult to treat, those who failed that regimen, actually most of them, if not all of them, responded to the dual DAA therapy.
Karen reminds me that we have about 5 more minutes in this section. Paul, question?
Yes, I enjoyed the comparison to say that the children's visits and how much that would equal the cost here. But in terms of other real-world examples of, say, a 1% per member per month impact, do you have any? I've heard from chief medical officers in the past when statins first came out that this was going to be a similar thing when defibrillators were being proposed. I don't know if that was at the 1% level, but there were similar discussions.
Yeah, again, I don't know, because this is not something that's been in the published literature. It's not as though there's a league table out there with other interventions that have been at or above this threshold that have been more readily accepted. I know that one of the benchmarks we published in our first report on this topic related to the PMPM impact of all imaging services to a private regional payer, and that was lower than the expected impact of introducing sofosbuvir plus PR into the armamentarium. So I think we will certainly start to look for those and see if we can find anything that uses thresholds that are similar or equivalent to what we used. I think that makes a lot of sense. I'm not sure what we'll find, though.
I have a question of Dr. Tice, just to get a feel, Jeff, for the data. There were only 2 combination groups that have FDA approval of the 4 at this point. You talked about most of them you had published data as opposed to abstracts. Is it fair to say that these are cherry-picked patients who are going to be very compliant drug company-sponsored studies, small numbers? In other words, how many patients are we talking about in this particular population? Is this thousands or hundreds or tens?
Well, it varies. I may have to look at the report and individual subgroups. In some of the subgroups, you were talking tens of patients with some of the therapies. For others, you were talking 400 or 500 patients treated. So there were some large randomized trials in some of these subgroups. So it varied, and really you can see that in the figures just by the size of the 95% confidence interval. You see some of them are actually quite small. So I mean, and when you, in truth, many of the trials included many more patients, but they had varying treatment lengths. Some of them also included ribavirin, where the FDA indication doesn't include ribavirin. If you pool all those together, you know, you get tighter confidence intervals, and pretty consistently similar findings of, again, 90, often greater than 95% SVR12s for the regimens, but several of them, in particular the sofosbuvir plus imipravir regimens and the decladisivir plus sofosbuvir regimen. There's only one study in each of those, and the numbers treated were relatively small in both of those. For LEDSOF and for the 3D regimens, there are much larger numbers of patients who are treated.
Okay, thank you. Is there any final question? If not, I'd like to go to the next section, which is a request for public comment. At this point, we have 4 individuals who wish to comment from the public microphone, and we would allow them each 5 minutes for an opening statement. And the first presenter is Robert Gish. Thank you. Thank you.
Good morning.
Morning.
I'm a practicing hepatologist, and I do want to give my potential conflicts of interest, and that is that I work with at least 20 different pharma and diagnostics companies in hepatitis space, including hepatitis B and hepatitis C, and I'll have a little bit of a closing comment about hepatitis B in a few moments. I practice in California, Nevada, and Arizona. I'm a clinical professor at Stanford and actually staff multiple Stanford liver clinics and work with the liver transplant program at Stanford, as well as establishing a new transplant program in Phoenix, Arizona. Most importantly, I'm the vice chair of the executive committee of the National Viral Hepatitis Roundtable. This is the leading advocacy organization for hepatitis C in the U.S. I'm the medical director for the Hepatitis B Foundation. That's in Doylestown, Pennsylvania. And I spend about 500 hours per year without pay working for a variety of nonprofits in the U.S. and worldwide. And I've been working in Vietnam, Philippines, Armenia, and the country of Georgia, working with healthcare policy directed at viral hepatitis in all these areas. These are obviously resource-constrained companies. But I'm going to put on a patient advocacy hat and a provider hat today and talk also about my clinical experience. I really want to, start with my closing statement, and I think that this organization be focused on treating all patients, not just F3 or F4 or some other criteria. Our group in Phoenix has treated over 500 patients with SOF-based therapies. We have 200 patients that have been treated or are on SIM-SOF right now. And Harvoni prescriptions, we've written about 200 prescriptions, and those patients are either on therapy or working through therapy. The biggest and the radical change that we've gone through is handling PEG interferon ribavirin side effects 3 to 5 years ago, which might take up to 40 or 60 hours per patient, to spending 5 to 10 hours per patient trying to get authorizations done. We're not dealing with adverse events. It is a little bit with compliance, but I'm working in a real-life setting where compliance is over 95%, and patients on therapy typically feel better while they're on therapy as opposed to PEG interferon. I think all those things are very important. I was really happy to talk to Jed earlier to see you've got a liver GI expert on your panel, and I think that's important. I think talking about quality of life is very important. I was impressed that that was being built in. The decrease in all-cause mortality linked to hepatitis C, I think, is very important. And you really need to think about hepatitis C as a systemic disease. There's direct links to B-cell lymphoma. That's a solid line. Recent implications about linkage to renal cell carcinoma. The impact on renal function. 70% of hepatitis C patients have circulating immune complexes that can be picked up by just a simple blood test called the rheumatoid factor. About half of them have low complement levels. So those patients have active immune complex disease. And I believe that explains a significant number of adverse events that we see in the patient with hepatitis C who have myalgias, arthralgias, as well as long-term impacts on renal function. There were questions about cherry picking. So in the real world, because I was involved with all the pegylated interferon trials with Roche, Genentech, and Merck and Schering, and yes, those patients were cherry-picked going into those interferon trials because if they weren't cherry-picked, they weren't going to stay on therapy. We had a huge problem with compliance and adherence in the clinical setting of using interferon therapy. I'll get back to that in just a moment. I really believe, because I was involved with the AbbVie, Gilead, Idenix, Merck trials with the hepatitis C drugs, that these are real-life patients. Why could we get real-life patients in? Is the phase 1b and the phase 2 study showed such a low side effect profile that we could bring in regular patients. And then we faced a dilemma about trying to compare these new drugs to PEG interferon and ribavirin, and we were not going to get that through the IRBs. We were not going to get that through informed consent. The side effect profile of these medicines are logarithmically less than interferon and ribavirin. In my practice, I would have a 7-page consent form for each patient to sign before I put them on PEG interferon and ribavirin. I've only been sued a few times in my life, and 2 lawsuits were over interferon side effects that were directly relinked. Thank you very much. So, in summary, I think all patients should be treated. We talked about residual effects of liver cancer risk in F3 and F4. We have hepatitis C as a systemic disease that affects renal, nerve, heart, eye, brain. I've seen all those different side effects. And I would really ask your team to model these cost issues. We saw numbers here at the end about this $30,000 to $40,000 per treatment range. More than half our patients will be on Harvoni for 8 weeks. We're not using PEG interferon anymore. Cimipravir is less than 1% of our patients, and basically no patients are getting 24 weeks of treatment. This is a real-world statement. Thank you very much for my 5 minutes. Appreciate it.
Thank you. Our next presenter will be, next speaker will be Dr. Sharon Levine.
Good morning, and thanks so much for the opportunity to speak. I'm here also representing a community of clinicians, the physicians who practice with Kaiser Permanente in California. And I really appreciate the work that CTAF has done, and also the limitations of the model. And I come here today to be certain that you understand the incredible dilemma that clinicians who treat Hep C patients are facing today. As my colleague Dr. Gish said, and Dr. Tice clearly articulated all the things we know about this. It appears to be very effective. It appears to have a much safer side effect profile than existing therapies. And we also know that the trials are based on small numbers. But if we assume that the trial numbers hold up in clinical practice, I think we have to face the fact that this isn't about meeting a threshold for a QALY of $50,000 to $150,000 per course of therapy to meet some threshold for consideration. Clinicians today are faced with the fact that they have a very effective therapy. They have been told for a decade now, and increasingly are stepping up to the challenge, that their job is not just to consider the needs of the patient in front of them, but also to consider that the trade-offs that the treatment of any given patient has on the needs of the community, of the larger community. And we've seen statements from ASCO, we've seen statements from clinicians at AASLD saying, this therapy works, it ought to be used, but we need to prioritize because of economic constraints. And the problem is, and I think the concern I have with the conversation up until this point is, all of this analysis is based on accepting the fact that the price as it exists is either acceptable, is justifiable, or in fact, whether there ought to be a broader conversation about how the value created, the health value created by these innovative models, these innovative therapies, ought to be distributed between the citizens of this country and the innovative manufacturers, accepting as in accepted wisdom, if you will, that these prices are justifiable, I think is something that we've gotten used to. And when we think about the 0.5% to 1% impact of a single therapy on premiums, we're ignoring the fact that the phenomenon that we've seen with the introduction of sofosbuvir has been, this was an effort to test the sky. How high could prices go before there was some pushback and someone saying, standing up bravely and saying, wait a minute, this may not be sustainable. If it meets the threshold for cost effectiveness based on QALYs, does that mean that it's affordable or sustainable by the healthcare system? I don't think so. And I think for the most part, QALYs have been used for therapies that affect a small population. We're talking about somewhere between 3 and 5 million people in this country. $2.8 billion, $2.3 billion best estimate for the Medi-Cal population. You know how much we spend on higher education for children in this state, and what the impact. This isn't, and the other issue is that this isn't an issue of health system value. It's an issue of health systems are just intermediaries. This is really an issue of value for the people of this state and this country, and what trade-offs, what cost-benefit trade-offs have to be made. And thank you. And to be honest, representing my colleagues, my clinical colleagues at Kaiser Permanente, a patient comes in and says, I've heard about this therapy, I've been diagnosed with hepatitis C, I've heard it's safe, I've heard it's effective, I would like to be treated. It is unconscionable to put clinicians in a position where they have to say, or even consider saying, you're not sick enough yet. So, as important as this work is, there has to be simultaneously in parallel to this policy work that goes on that calls the question of the pricing of these drugs, not the value, but the pricing of these drugs, and how much profit is legitimate and justifiable, and how does that value get distributed among all the stakeholders in healthcare. Thank you.
Thank you. Our next presenter will be Bill Remack.
Good morning.
Hi.
My name is Bill Remack. I'm 61 years old. I'm a medical technologist and have a degree in public health, and was previously on the staff of the pathology labs at UCSF and San Francisco General Hospital. For over 20 years, I've been a patient and a health policy advocate for chronic and liver diseases, and also organ donation. And I want to thank you for giving me the opportunity to speak with you today. I've served on the board of directors of the American Liver Foundation of Northern California and Nevada. I've helped founded the California Hepatitis C Task Force and the National Association of Hepatitis Task Forces. And I'm a founding executive board member of the California Chronic Care Coalition and executive director of the National Working Group on Evidence-Based Healthcare, and the community advisory board member of the VA Hepatitis C program, and also on the community advisory board of Partnership Health Plan of California, the managed care plan for over 14 Northern California counties. And in addition to that, I'm a member of the Gastroenterology Nurses and Associates, Association of Healthcare Journalists, National Viral Hepatitis Roundtable, and World Hepatitis Alliance. And I'm board secretary of the FAIR Foundation and National Advocacy Director, and this is for organ transplant reform measures. I'm also a core member of the drivers behind Proposition 71 that saw the passage and creation of the California Institute of Regenerative Medicine and provided perspective on the initial governance. I'm here primarily to bring you a patient perspective, and perhaps you'll consider my story in the context that we now have a tremendous opportunity with the development of these direct-acting antivirals to change the future with a vision of eliminating hepatitis C. My story paints the picture of the past. The past is something we learn from, and for nearly half a century, since I was admitted with acute liver failure to Kaiser Hospital ICU in San Rafael, California, back in 1967, then called chronic persistent hepatitis, or non-A, non-B hepatitis, and later in the 1980s called hepatitis C. And while through all those years with routine medical exams and tests, this illness slowly eroded my health despite very active and relatively healthy quality of life, in which I got an education, embarked on a career, married, raised 4 children, and now have 3 grandchildren. Life has thrown some curves, but I'm here today because of the research and the science. The skillful application of medicine by a team of thoughtful and motivated doctors. I knew how to navigate the system, and knowing that giving up was not an option. And last but not least, my determination was to survive. The last 25 years has been a contest of endurance. My medical background and knowledge has played an important role in helping me succeed, along with the support of my family and friends. In 1990, bacterial spinal meningitis nearly took me. 95, my gallbladder was removed. 98, hepatocellular carcinoma and a liver transplant. And from 1999 to 2006, I endured 3 complete 48-week combination therapy treatments. Thereafter, another 3 48-week full treatments of pegylated combination interferon. So that comes to 6 full treatments. Liver transplant, again, in 2007. And since 1996, I've been insulin dependent with type 2 diabetes, have bone degeneration, osteoarthritis of the spine, stage 3 chronic kidney disease, and I still have hepatitis C genotype 1. After 48 years, now is my chance to be cured. The difference is that these treatments really work. So, in the interest of time, let me say that this research has yielded a pathway of hope for many, and as we sit here today, I'm involved in many efforts that will help build and educate a workforce capacity, deliver the necessary hepatitis C specialty care, and needs to compensate for provider and specialty care shortage. New science must be allowed to progress. Transplantation, regenerative medicine, personalized medicine, stem cell therapies, and precision medicine are with us today. And this science is a technology that's helping change the world for people. And when it's about people, then it's about health. Thank you for listening.
Our next presenter is Emily, and forgive me for if I murder this, Hirio.
Very good.
How college French.
So my name is Emily Hirio. I have no conflicts of interest, and I am the Director of Federal and State Affairs for Project Inform, which is a HIV and hepatitis C patient education and advocacy organization. And my first and key comment, just to correct Dr. Tice about our key comment from Project Inform, is really that the report fails to examine infections averted through various treatment strategies and the implications of cure as prevention, and looking at reinfection as well. And particularly among people who inject drugs, women of childbearing age, and people in prison, this examination is critical. We feel that this omission leaves the analysis woefully inadequate to assess the implications of the various strategies outlined in the report, and we do highly recommend that you at least mention this in the report, even if you don't have great data on it in the final analysis. We do think this component is critical to understanding the value of these novel treatments, both from a public health perspective and for payers, such as Medicaid programs and prison health systems that likely have a large representation of people who inject drugs. And I wanted to note that some lovely people handed out some flyers that many of you might have received in front of the building this morning, and this does address some of those issues in terms of injection drug use, and I hope if you did get it that you read it. I won't go into my comments about quality of life because I feel like Bill Remack and Dr. Gish really covered those, but just to add a concern that we had that there doesn't seem to be any voting members of CTAF that are Hep C patients or liver or Hep C medical experts. We do feel like that representation is critical to understand the effects of Hep C on patients' lives and to outline the extrahepatic conditions and the related costs caused by hepatitis C. It was mentioned briefly this morning, but there is some outdated data in the report because it was written before the liver meeting. So we hope that you'll go back and include some of this data. 2 examples. On page 31, there's a reference to the NIH Eradicate trial that assessed Harvoni in HIV and Hep C co-infected persons. And in the report, the EASL data from April is provided that SVR was only available for 10 patients. At the liver meeting, there were data presented that 49 out of 50 achieved SVR. Similarly, there was good data presented on post-transplant treatment and cost effectiveness, and we suggest the analysis look at that data for the final report. Also, the Hep C target study is looking at real-world treatment outcomes. They've seen very good treatment outcomes that are very similar to the clinical trial outcomes, and we hope that that will be considered in the final report. This was mentioned earlier, but something I think worth repeating. The assumption that 50% of genotype 1 patients who know their status will be treated in a year seems wildly unrealistic to us, given that current rates are 15% in an optimistic assumption. And the history of addressing HIV, which is a similar chronic infectious disease, really provides a useful analogy for this. Even with our significant investments in HIV treatment, testing, and care, over the last 30 years, we only have 33% of Americans with HIV prescribed antiretrovirals and only 25% virally suppressed. Dr. Ward from the CDC has estimated that it will take at least 15 years to successfully test and treat everyone living with Hep C. We have significant provider shortages. We have patients who are not engaged with healthcare providers, even if they have insurance, and who have competing priorities. And we have many patients and providers who are avoiding testing because there's the perception that treatment's unlikely. So we really recommend reevaluating that 50% assumption. We think it's way off base. We also think the timing of the report is very unfortunate, given that the AbbVie regimen and the price will likely be announced tomorrow. And we hope that you'll revise the analysis to include the price of 3D. This would be critical to providing the most useful and applicable document for policymakers. And then we really do think that the focus of this meeting should be on strategies for curing everyone living with this common chronic infectious disease. We're in a situation where Hep C treatment is clearly cost-effective in the long term, but we have short-term purchasing problems given the price. And we hope that Medicaid programs and prison health systems and other payers will examine creative purchasing strategies. For example, Medicaid programs could work across states on collective negotiations and purchasing. So I appreciate your careful consideration of all the public comment, and thank you for your time.
We have 2 more who wish to comment, each of whom will be allowed 3 minutes for a statement. The first is John Rother.
Good morning, and thank you for the opportunity to comment. My name is John Rother. I have no conflicts of interest. I am the president and CEO of the National Coalition on Healthcare based in Washington. It's an organization of about 80 large organizations that represent providers, payers of healthcare, consumer and patient groups. And our mission is the affordability of our healthcare system and the value of it. So we're very concerned and very supportive of the effort here to better document and analyze what value means in the pharmaceutical area. I have 3 comments I want to make. And the first is to appreciate the fact that you've addressed affordability directly, because affordability is becoming the key issue now for healthcare, not just for this therapy, but for the therapies that are now in the FDA pipeline coming our way, most of which in the biologic area, cancer drugs, are going to be quite expensive. And so what we apply here as a standard has to be in the broader context of affordability for many new therapies. Many of them will be effective, but we are right now just at the beginning of the effort to try to better balance effectiveness with affordability, and I urge you to consider that broader context in your work. The last paragraph of the handout today did a very nice job at articulating what this means in terms of issues that will be represented to the Congress and other policymakers given the price structure. I do think, my own opinion is that the current therapies are mispriced. As your analysis shows, if they were significantly less, we could treat everyone at an affordable level. And I think that is quite significant and worth holding up and emphasizing in your report. The final comment I want to make is, I know this is difficult, but in terms of cost effectiveness, healthcare systems do not have unlimited budgets. And the decision to spend more in one area means you spend less in another. Dr. Winslow made that point very well. It's not really, in my mind, valid to look only at the costs implied by a new drug without looking at the trade-offs. Whether it's the VA, whether it's Medicaid, whether it's prisons, or whether it's private health insurance, there are trade-offs. And I think part of the consideration here, although it's very hard to measure, has to take into account the impact of those trade-offs when we have an excessively priced new therapy, admittedly quite effective, but still, given the budget impact, requiring some very painful decisions about trade-offs, or, on the other hand, limiting who can get the drug, even though the drug would obviously benefit those people. So there's an obvious solution here that has to do with price, but in the meantime, I urge you to take into account a broader range of issues when it comes to affordability. Thank you.
Thank you. Our final public comment will come from the Reverend Peggy Moore.
Thank you. I'm speaking here as a patient. I'm a nurse and a priest, but I want to give a perspective that hasn't really been talked about. While I was waiting for effective treatment and getting various other kinds of treatment, my body slowly deteriorated during that time. My ALT and AST were pretty good. My platelets were a little low, but basically I could have been considered close to asymptomatic. But I wasn't. During that time, my cognitive function, and in particular executive function, declined steadily, not to mention my energy decline. On Sunday, during Mass, I couldn't remember where I was in the service, and I couldn't pick it up again. A lot of people forget where they are during things, but I could not retrieve it. And I preached for the wrong Sunday sometimes, and I had continuing deteriorating function in that role, rude pastoral care, some other kinds of things. And I eventually had to just quit doing it, which is why I'm retired. Both my careers, nursing and as clergy, were essentially destroyed during the waiting time that I seemed pretty healthy. I would not have been in the top priority of treatment. My liver and brain were being destroyed too, and my family relationships were hugely strained. Earlier in the course of the disease, even I might have said that I had no real symptoms because I couldn't see it from the inside. People waiting for treatment aren't static. We are not holiday ornaments on the shelf waiting for the right season. We are people with a disease process happening and continuing and going on and deteriorating. And to determine that some people should not be treated is just inhumane. I appealed to the pharmaceutical companies, the insurance companies, to doctors, to policymakers, and to all involved to cooperate to treat everybody infected. This is an infectious disease. It's not a well person visit. It's an infectious process that affects the whole community. Lower the price, charge on credit, develop long-term contracts, appeal to the need and ethics of this to shareholders, of which I am one. Do whatever needs to happen to make it work. Treating everyone now may seem extreme and naive, but these are the infectious epidemic conditions of total emergency. Bite the bullet in the interest of long-term gain. Sequential treatment is short-sighted and probably not even the best financial solution. Not to mention, it is inhumane. Scripture says, what profit is it if you gain the whole world but lose your soul? I have to do that, I'm a preacher.
As an incentive to return after lunch, I want to point out that the Reverend Margaret Moore, whom we can call Peggy, will be on our roundtable later.
Thank you. The next section is another opportunity for the panelists prior to voting to ask questions. And at this time, I would like to ask some of our clinical experts to come forward and join us at the dais. Rena Fox, Joanna Reddy, Mitch Katz, Juan Carlos Lopez Talavera, and Bill Geyer. Would you come forward, please?
Please find the bios of all of our participants and experts in your handouts and packets. If we went through everybody's, it would be tomorrow.
So thank you all for joining us. We as panelists would like to ask some questions preparatory to our votes. So panelists, any questions of our clinical experts on this whole subject? Yes, Alex.
Yeah, I just like to push again on this issue of real-world clinical effectiveness, and so I'd like to hear from you folks what you're seeing as far as treatment responses in the patients you care for.
There were two big studies at the liver meeting last month called the Target study and the TRIO study, and they were primarily looking at semaprevir sofosbuvir regimens in the community with rates, SVR rates that are around 86, 87%, which is lower than clinical trials. It did have some higher dropout rates. I think they were considered, I mean, and those are ongoing. They're considered, I'd like to hear what everybody else has to say about this too, but I think they're considered successful. Those are successful rates, but not as good as we saw in, for example, the Cosmos trial, where the arms were incredibly low, small ends, and SPR rates were much higher there.
The I would reiterate that as a clinician who's treating a fairly sizable number of people with Hep C, even though it's easier than what the interferon regimens are, and I mean, interferon is a thing of the past now. No one's ever going to use it again. It is hard to get people through the entire regimen, even if it's only 12 weeks. And we are seeing a few relapses at week 24, 36, and along those lines. And looking at the data now and looking forward to the EASL data to see what we're going to be able to use in the future.
I have a...
if you don't mind,
yeah, please,
I'll comment.
yes,
So from
please.
a Gilead perspective, because we were a sponsor of both the Target and the Trio cohort, and one of the great things about the Target cohort is I think every hepatitis C company sponsored the Target cohort, and it's a partner with the FDA. And so when you look at the results, while overall discontinuation rates may have been higher than clinical trials, they still were, I think, fairly low, and especially the discontinuations due to adverse events. And both of those analyses of 2,000 patients total, the discontinuation rate due to an adverse event was only about 1.5%, which was exactly like clinical trials. So looking at the safety perspective of it, we saw a really good safety analysis. And that's always something that's new, that when you take a clinical trial and you put it out into the patient population, will you see a new adverse event? And we did not see any new adverse event. And we do consider them a success because some of the analyses were exactly like in our label. If you look at treatment-experienced patients, the FDA made an analysis where it would be about 71% would be cured. In the Target and Trio cohorts, it was exactly 71%. And so that was kind of reassuring. Other analyses, yes, were a little lower, and I would advocate that, yes, they were a little lower, but I think being in a real-world population, 89% cured is a fairly good increase from what was seen previously. Telaprevir, boceprevir in the real world only got about a 40% cure rate. And so we were doubling the cure rates in those. And I think one of the reasons for that is we tried to take a methodical approach that was mentioned. Did we cherry pick? We tried to learn from that of not cherry picking patients. We tried to leave it up to investigators to have no upper limit of age. The oldest patient in our trial was 80. No upper limit of BMI. The biggest patient in our trials were 56 BMIs. We allowed patients who had multiple negative predictors. African Americans were mentioned earlier. 16% of patients were African American in the Harvoni trials. We did an analysis on African Americans. 308 African Americans had an SVR rate of 95%, non-African Americans 97%. We allowed opiate replacement patients to come in, patients who were previously IV drug abusers. We allowed cirrhotics into our trials. We tried to create real-world-like trials. Even though, yes, they are a company-sponsored trial, we tried to create real-world-like trials.
Thank you. Thank you very much. Just a couple of clinical questions. Are your primary care physicians actually screening for the baby boomers, and are you seeing some results from that in terms of patients referred to you? And secondly, I remember in our March meeting there was a comment about the cost of the drug, whether you would hand somebody a bottle of pills that was worth $85,000, or would you ask them to come in and watch them take the pill? Any comments on those two issues? Rena?
Well, I'm a primary care physician as well as a hepatitis C treater. I'm sure different systems have approached this differently, but at UCSF in our general medicine practice, we have a computerized reminder to screen all patients born between 1945 and 1965. I don't know how well we're doing with that yet in terms of actually getting the tests done, but it's certainly helping. And I think it's become more widely accepted. The data I've seen about how well it's been picked up, at least one study that I can think of showed that after the recommendation was promoted, that there was about 6 months or 12 months of increased screening, and then it kind of dropped off again. So I think if a system wants to promote that, they may need a systematic way of reminding people.
Thank you. What about administering
DOT.
expensive pills? Do you?
I don't practice that way. I've been very careful about treating patients who I think are going to be extremely compliant and reliable. But I think when you are treating maybe a more indigent group or one that with less stability in terms of housing, that's something you can consider.
LA, maybe LA County could comment on that?
Sure. Well, the LA public system has traditionally had challenges meeting very basic levels of recommended care. The work that I've been doing during the last 4 years has been mostly focused on trying to meet things like having a primary care doctor available for a chronically ill patient. And we've impaneled 450,000 people. But that's a completely new phenomena for a system that only once provided emergency care. We have not been universally doing hepatitis C screening. We are treating people for hepatitis C, and we certainly intend to broaden that with the new drugs available. But we have not aggressively done the hepatitis C screening.
Just a follow-up question. Have you not done it because you feel why screen for a condition that you, in fact, don't intend or can't afford to treat?
Marge, it touches on a lot of the issues that people have raised. My system has a fixed budget. And so it's a question of what are the things that are going to give us the most health for the amount of money that we have. And at the moment, for example, I would feel more strongly about treating someone with hepatitis C than I would feel about a broader screening campaign, because I have a large number of people who need treatment. And as other people have alluded to, the systems for making that happen, especially among people who often lack transportation, who have unstable living arrangements, is difficult. And so from a prioritization point of view, I want to work first on treating those people who need treatment, and then later look to screen people who are currently doing fine, not aware of it. They would fall in a fixed budget perspective as the next, not the first.
I take care of a large number of patients with Hep C at Kaiser Permanente, and what we have done is initiate a series of lectures and grand rounds for the internists, the family practice doctors, OBGYN, to educate them about Hep C and who needs to be screened, how do you screen, and what does the screening mean. Specifically in terms of making sure that those people that do test positive for the antibody actually go further and get a viral load, because that's become increasingly acknowledged in all sorts of healthcare settings that people get tested and then don't really get any kind of follow-up. Once someone is diagnosed, then they do enter into a sort of a labyrinth of Hep C classes, going into Hep C providers and initiating therapy at some point in time when appropriate.
DOT?
I'm sorry?
DOT?
DOT.
Directly observed therapy.
Oh, sorry. No, what we do is we give out medication at 2-week intervals. And that's basically what we've done. We do not make people bring bottles back in. We don't count pills, things along those lines. But we will give out 2 weeks at a time. Because surprisingly, we had several patients who lost bottles. I mean...
Marge, go ahead.
I'm curious. It's always been considered verboten to talk about the cost of care at the bedside. But this one feels different. Do you actually tell your patients, this is $1,000 a pill, don't lose them? I mean, and sort of the broader impact on the cost to everyone else. Is it finally time to actually say to patients, we need you to help us here by being responsible?
Speaking for myself and my colleagues, I mean, we have those conversations all the time. I mean, typically what I will say when we start with the first, bottle of pills is, I'll just say, here's your Tesla. Because it is. It kind of lightens the moment a bit, you know?
Yeah.
But it is.
Any other questions? Yes, Christine.
I would like to get more information on the question of asymptomatic hepatitis C infection. We've had some testimony today that, in fact, it's not asymptomatic. What do we know about symptoms with people of different stages of fibrosis? This is the first part. Second part is how practical, I guess, is short of liver biopsy, some of the other methods to stage people.
Thank you for the question. The practicality of the liver biopsy is tough, and unless you have been trained for that. I was surprised actually to hear about during the residency in general medicine to be able to perform liver biopsy. I was trained, I'm a hepatologist trained in Barcelona, the liver unit, and then I moved to the US, Yale and Pittsburgh, almost 25 years ago. And that's a procedure that even to the physician today, it makes you nervous. So you have to be careful with that. And fortunately, with these clinical trials, we have been able to develop, liver biopsy has been able to be avoided. There are non-interventional methods to basically to assess, or at least in a more or less accurate way, the amount of liver fibrosis. So as much as possible, we are trying to avoid to get into that. One important issue that was brought before is about why F3, F4. When you have a liver biopsy result and you see that you have signs of being F3, you know that at least it's going to be F3. Many times it's already F4 too, right? And that's a way also that you, in a way, put the patients together. Going to your practical question and answer, we're trying to avoid the liver biopsy because of the complications, although sometimes you need to do that to at least to disregard or discard other pathologies that may be there. Do you have another part of the question, right?
The asymptomatic.
The symptoms. Earlier, yes, it is true. The patients have less symptoms, but there are, as Dr. Gish mentioned, sometimes you don't realize you have those symptoms, and patients tell you, and the physicians here, they can tell you too, that once you start treating the patients, they can tell you, damn, I didn't know I was actually feeling so sick or I was so tired. Even symptoms of depression and other concomitant diseases too, in addition to the ones that Bob mentioned in terms of the complications long-term too. Once they start developing fibrosis and cirrhosis, there are other complications of that advanced liver disease, derived from portal hypertension to even the development of even liver cancer.
Thank you. Yes, Kimberly.
I think Christine is not done. She was going to ask something else.
Yeah, I guess what I was looking for more was, do we have evidence, has there been observational study of classes of people with different level of fibrosis to identify whether or not there is an asymptomatic state or whether some of these more ill-defined, although real to the patient, symptoms are attributable to Hep C or attributable to other things. And it's one thing in retrospect to say I feel better after I've been treated, but that's anecdotal. Do we really have anything that strongly associates that? And then the second piece is again, the FibroScan and some of the other arrays of lab tests. How accurate are they in stratifying fibrosis levels?
So there have been, yes, studies showing that in terms of quality of life and symptoms that are associated with hepatitis C, and they are either disappear or diminished. So there are studies about that. And in terms of FibroScan and these non-interventional, non-invasive methods, they are pretty good assessing the existence of cirrhosis, but they are not good at all telling you the degree of fibrosis. Just to tell things simple.
Kimberly.
I was just wondering, Dr. Reddy, you mentioned that you're counseling OBGYN, so are pregnant women candidates for treatment for this? Or?
Are pregnant
women, if they're on...
No. But it would be a public health issue that if you have someone of childbearing age, should we be targeting them as for treatment so that we eliminate the risk, very small, of vertical transmission?
Yes, Bob.
I really don't know who to address this to directly, but I'd kind of like to see if you all could take at least the first stab at what a number of people kind of dance around here. at putting the two and two together, we are talking about a 15% service, about 15%. We can handle about 15% of the population is the number we keep throwing around, and that's about what presents, apparently, right now. This is clearly a candidate for, if there's ever going to be a drug development candidate, this may be the first one for moving something from the specialty care venue to the primary care, easily diagnosed and oral administration with single pills. I mean, what's not to like about that? We're dancing around the cost of the drugs, but we're not having any problem selling it, apparently. The numbers are quite scary. Very impressive from the, financial aspect of things. And we're talking about whether we should stratify somehow patients in terms of who gets access to it and when. What are we doing about that right now? How is the drug actually selling in here? Somebody's getting approved somewhere for payment. It's selling into the system. Somebody's paying for it somewhere. We're servicing X number of patients at what level? I'd appreciate it. I realize it's kind of a general thing, but I'd appreciate it if you all would take a stab at trying to put those two and two together. Yeah, I keep looking at you, Rena. I'm sorry.
It's okay. I just want to make sure your question is, number one, I think one of your questions was, should non-specialists be prescribing?
Well, we're looking at a thing here. Our system can't handle a huge influx of patients, right? So we have to have a change somewhere.
Right.
Is that a viable thing? And is this an example of? The other thing that we're talking about in background conversations about this is a canary in the coal mine kind of example. This is we're talking about drug development heading this direction in the future. These kind of things happening, and this is the first one that appears to come out of really small groups of patients. Rare diseases. This one kind of doesn't really qualify on that score. It's a bigger animal here. So specifically that kind of thing, is that one of our cost savings? I realize it's not major in comparison to the price of the drug. But again, we're not having trouble selling the drug apparently, so I'm wondering how this is all really working.
From a equity standpoint, or thinking about disparities in healthcare, there are, I think, 1,800 hepatologists in the U.S., so there are not enough hepatologists, nor infectious disease specialists or general gastroenterologists to treat all hepatitis C patients if we were going to restrict it to specialists. So if the goal is to restrict the number of prescriptions being written, that is one technique to do that. If the goal is to try to treat as many patients as we can who are appropriate for treatment and safely and using the drugs appropriately, then I do think that non-specialists should and can prescribe with either some basic training or access to consultation if they want to confirm the regimen that they're choosing. It's not hard to prescribe. It's not complicated in terms of follow-up. And with an 8 or 12-week regimen, you'll complete their treatment before they get their appointment with a specialist. So that's what I would say about that question.
Just say, to agree with Rena, for LA, that's we're in the process of that, which is to say, I mean, we don't believe it requires a hepatologist, and that would be an absolute obstacle to the treatment. In fact, one of our clinics is running very well with the nurse practitioner who does everything after the initial visit. And she does a spectacular job because this can be easily turned into a protocol so that you follow all of the things. And when someone acts differently than the protocol, that's when you obviously need more help in order to do it. But we're going to do it with a large number of team people to try to deal with some of the issues that people have raised about compliance and keeping track of the pills and adherence as we go forward.
So let me make a comment of what we've seen. So we publicly stated that we've seen about 100,000 patients treated in the first 3 quarters of this year. So if you model that out, it might be around 140,000 treated for the full year. If you look at the total percentage of patients then identified, that's about 8% of those identified. So even if we doubled that number, and the system, I think, is already pretty full at the number of people being treated now. So doubling that to get to 15% would mean you'd have to treat 300,000 patients in a year. That would be a big undertaking. So treating everybody in a year, I would agree with one of the panelists or one of the comments, it's almost impossible based on the system that's there. And it's going to take a tremendous effort even to double it to 15% to treat that many.
Bob, the other part that I heard in your question was, given present practice, is there some selectivity or rationing going on, or are patients being treated as they present? And I haven't quite heard the answer. What do you say about that? Are you pretty much treating everybody that presents, or?
Well, I mean, if you're dealing with a multi-payer system, then there are two factors driving whether or not a patient gets treated, aside from the patient themselves. One would be the clinician's decision, and the other would be whether the drug is authorized. Mm-hmm. So the clinician may decide to treat their patient and the drug not be authorized. So both of those levels are being passed. I mean, I think that I completely agree with Dr. Gish's comment about we're not dealing with side effects, we're dealing with authorizations. That's completely true.
Thank you. Yes, Christine.
Yes, I'd like to follow up with what the gentleman from Gilead just mentioned. So you said you had 100,000 patients treated in the first quarter?
First 3 quarters.
First 3 quarters, okay. And retail cost about $84,000 a treatment course. That's $8.4 billion that Gilead has in revenue from this medication. So going back to some of the commentary we heard earlier, what has been your expenditure on developing this medication to date, and what is your profit margin?
So I'm the medical affairs person. I am not the best person to comment on our financials, I'll be honest. I think that would be best for our next panel that talks about cost and value. I could speak to all the clinical data.
Thank you for saying that. We are starting to verge into what's going to happen this afternoon, so I would urge us to talk about the clinical practice in this particular section. Yes, please. Meg.
Another one for you, Rena, about, well, I don't know about whether it would work for Kaiser as well, but questions around the authorizations and whether you're able to either know specifically or discern the policies from the insurers around their authorizations. What are Kaiser's policies? What are you finding from the multiple payers you're using in terms of whether they're approving or not? I know from a prior job I had, we would have to specify what the actual policy was when we were approving or denying services. So what can you tell us about what you're experiencing?
It's somewhat heterogeneous. In general, I would say that prescriptions have been restricted to specialists and have been largely restricted to patients with documented F4 or sometimes F3 or with documented extrahepatic manifestations. So I would say those are the themes that we've encountered. I mean, but as an example, I saw somewhere that there was a hope for some anecdotes. So as an example, I had a patient who has very easily documented cirrhosis, but not with a biopsy, with every other possible evidence of cirrhosis, and he was denied treatment over and over because he did not have a biopsy. So we eventually appealed to the Gilead support path for charitable drug, which was successful.
Are there other exclusion criteria you're experiencing around vulnerable populations, IV drug users, co-infection with Hep B or HIV or other things which are being considered exclusionary criteria from payers?
It was, well, in terms of sofosbuvir, that was approved for co-infection with HIV, not with hepatitis B. So that would not be an exclusion.
The way we have it set up at the present time for Kaiser in Northern California, every medical center has a treating group that includes GI, ID, internal medicine, a nurse, and a clinical pharmacist. And we've been actively going after people that we know have F3, F4, either by biopsy, fibroscan, or lab tests. All of the identified HIV co-infected patients. Haven't really looked at B co-infected yet, although we will need to in the future. And so we're going after those, but when someone is diagnosed and they want to be considered for treatment, then we are still bringing them in and having them go through and see one of the doctors, ID, GI, internal medicine, that have an interest in it.
Does Kaiser have a policy about which, and I would say, I know Northern, Southern, I think tend to operate separately in terms of policy creation, but are there written policies about who's in and who's out?
No. Okay. When we don't have that policy and we are treating people that are not F3, F4, as they come through based on, we've got 15 different tiers of copays now, so that's a big thing too, especially for the Medicare people, because we need to make sure we treat them in the right time of year so they only go through the donut hole once. And so there's a lot of, sort of machinations that we're going through with that. But we're treating non-F3, F4s. We're going after the F3s, F4s because we know they need to be treated now.
I would agree. The same, except with a little less resource. That's. It's okay. So we don't have any explicit cutoffs. The goal is to treat the people who most need it first. Not to say that that'd be the only group you would treat. Just that you should treat the people who need it the most first, and then get to the group who next most need it. But we don't have any explicit cutoff.
So if you have a savvy patient with not too many symptoms who comes and demands treatment, isn't F3 or 4 up?
They would probably they would get it. I think consistent with Kaiser, even though I'm practicing, I don't believe on trying to administrate what doctors do. I would never review someone's record and say, why did you treat this person when we don't do that as long as you treat within reasonable community standard, which the data would support would be anyone with Hep C. But as a system like Kaiser, it makes sense to try to treat those people first who most need the treatment and get to the other people at a later point.
Okay, I think we'll break it off at this point. We have to get on to the voting. I want to thank our clinical experts for their testimony and turn it over to Dr. Weisberg.
Thank you very much, Dan, and thank you to our clinical experts who came and enriched our discussion. As Dan pointed out, many of these topics will be those we go into even more depth later this afternoon. Now, we're going to talk primarily to our advisory, to our panel, to our CTAF panel. And while this may leave the audience a bit feeling neglected, this is a very important aspect of the CTAF process in that we do our voting explicitly and in public. And as we noted with our training earlier, we will be collecting people's thoughts and deliberations so we can accurately represent those in our final report. So our voting questions have this format. Our panel knows this. We look at comparative effectiveness kinds of arrangements. Is the evidence adequate to demonstrate that intervention A is superior to the comparator B for patients with conditions X? And it's a yes or no vote, which we'll be collecting in an automated manner and displaying on the screen. We define care value by going through the following elements of reasoning. We look at the comparative clinical effectiveness, the incremental cost per outcomes achieved, the additional benefits that are not represented in the first two buckets, the contextual considerations, namely things like no other treatments, terrible impacts on others or society, the care value, which is the compilation of those first four things, and then bring in the concept which has been referred to several times during the comments and discussion, that of affordability, either from the perspective of an individual, a health system, or society. And we ask our panelists, under the view of the public, to make a determination as to whether that value is high, reasonable, or low. And those are the votes we'll record. I'm going to, for the purposes of getting right down to it, accelerate a little bit here. We're going to do a practice question in terms of just testing the voting mechanisms, and Matt's going to explain exactly how those fancy remote controls work, and then we'll get back to the questions at hand.
Hi, how you doing? So as many of you have probably noticed, you have a little red remote in front of you. So if you hold the on-off button, which is in the upper left corner, it should turn on and search for a session. And then it'll ask you to enter your ID. Now, on a Post-it note on your name tents, there's a number. So if you enter that number and then hit Submit, which should be the upper right button, it should allow you to access the questions.
Join? Join?
Join, yes. Join. So if everyone's there, everybody should be able to see several options, A through C. Now to access...
How do you indicate B?
Oh, okay. So to access the vote that you'd like, you can use the up and down arrows on the keypad to scroll into the selection there. And then when you've found a selection that you like about the drought, you can then hit Send, which is again the upper right key.
Somewhat B. Is that highlighted? So we use these up or down.
All right, so we've got all 12 votes, and then we can view the results, which will look like that. Now, if any of you happen to want to change your votes before we display the answers, you can change your vote using the key under the change vote, and it'll just bounce you right back to the A, B, and C, where you can then repeat the process.
So I can
For the next one, is there some way to erase this?
It'll clear out.
Is our panel now skilled with voting? Okay. The Supreme Court will be examining this methodology later, so be accurate in what you do. So now we're going to go ahead and get to the care value aspects of our questions. And Matt, could you change the slide? I do. Okay. Okay. So much of our review of the clinical evidence and indeed the economic modeling, but here we're looking at the clinical evidence, is comparing current best known therapy, lead-soft, versus 2 years ago best therapy, perhaps, which was a PR kinds of regimen, or maybe 3 years ago. And the question is, for patients with genotype 1 chronic hepatitis C infection, that's the scope we've indicated our evidence for and what we're voting on, is the evidence adequate to demonstrate that clinical outcomes with lead-soft are superior to those provided by treatment with pegylated interferon plus ribavirin? And that is yes or no. We'll ask you to either any clarifying questions about the wording, then we'll ask you to vote. We have a unanimous vote. And that's how many panelists we have, Karen? Okay, we are past our first vote. Let's look at voting question number 2. Question number 2. You have your reference again. We're looking at the lead-soft comparison, but this time against soft plus PR, a more recent standard of care. And the evidence is summarized for you on your handouts if you want to look at the graphs again. For patients with genotype 1 chronic hepatitis C infection, is the evidence adequate to demonstrate that clinical outcomes with lead-soft are superior to those provided by treatment with soft plus PR? Any questions about the question? In that case, we'll ask you to vote, yes or no. Okay, we have a majority vote saying yes, the benefits are superior to soft plus PR. 2 people said no. Go to question number 3, please. We are now looking at a different comparison. Lead-soft, the most recent standard of care versus SimSoft, perhaps one before. For patients with genotype 1 chronic hepatitis C infection, is the evidence adequate to demonstrate that clinical outcomes with lead-soft are superior to those provided by SimSoft? And you might want to look at Jeff's summary tables of SVR and the uncertainty as you consider the answer to this question. When you're ready, you may vote yes or no. So here we have the majority of respondents saying no, that lead-soft is not clearly superior to the SimSoft prior standard of care. Can we go to voting question number 4? Question number 4. Now, this is the most recent update, and as you saw, we don't have a lot of data necessarily or the pricing on this combination, but we do have some clinical data for lead-soft compared with what we've seen for the 3D plus R regimen, the one that has the combination of direct-acting antivirals plus a booster with or without ribavirin. And this is with the ribavirin. For patients with genotype 1 chronic hepatitis C infection, is the evidence adequate to demonstrate that clinical outcomes with lead-soft are superior to those provided by treatment with 3D plus R? Again, look at your tables of SVR and uncertainty and vote yes or no. So the majority voted no. We are not certain that the lead-soft is superior to the 3D plus R. Thank you. Any questions about that voting before we go on? Okay, now we get into the combination of the care value plus the overall value to the healthcare system. Right. Just for the panel now, remember we handed these out earlier so we could capture some of your thinking about how you reasoned this, and I just want to restate it. So this is lead-soft versus PR, the old standard, in terms of the care value. This is bringing the price and the economic analysis that has been presented to you into the thinking in addition to the clinical value. So I'll read the question, and then we'll see if there are any comments or questions about that. If yes to question 1, which was voted yes, lead-soft was clinically superior to PR. Given the prices presented in the report, what is the care value of lead-soft versus pegylated interferon plus ribavirin? Is that low, reasonable, or high? Any questions about the issue under vote? In that case, go ahead and vote. Low, reasonable, or high. Use your arrows to go up and down. Okay, everybody has voted. So A was low, B was reasonable, C was high, and preponderance of votes are reasonable or high for the lead-soft PR care value comparison. Now, you know who, we're not going to reveal who voted what, but you know who voted what, and we'd like you to write down on your form the rationale, the reasoning you went through, so that we can capture that for the discussion in the final draft, the final document we publish. So write that down on that form that's in front of you, and we will want to ask perhaps representatives from all three of the voting categories their thinking. I see many people have noted comments. This will make Steve, Karen's, and my job of reporting all of this in the final report that much easier. Would anybody like to just say a word or two about the thinking and rationale, the process they went through as they were putting together clinical value and the cost information in the LeadSoft PR comparison? Any comments to share? This one might be too easy. All right, we'll take that as a challenge for our final voting question. Can we see voting question number 6? No, we're still on. Yeah, there we go, 6. This is LeadSoft versus PR for the overall health system value. Assuming no changes to pricing or to payment mechanisms, if a policy strategy to treat all known infected patients was adopted, what would the health system value of LeadSoft be for a state Medicaid program? And this is compared to PR, low, reasonable, or high. And if you want to have any discussion of this question before voting, raise your hand, let us know. And obviously, from the comments and discussion we've already held, you know that this afternoon we will be talking about potential alterations in price or payment or other kinds of approaches. But for now, for this voting question, given our inability to change those things at the click of a finger, do you consider the health system value, LeadSoft versus PR, to be low, reasonable, or high? So record your votes, the arrows, enter, and your thoughts on your crib sheet. So the majority said the health system value was low. A few said reasonable. A few said high. I would invite. Oh, you want to change it?
Yeah.
Can we allow Marge to
I
change it?
misvoted.
Okay.
Okay, let's see how I do that.
Now you're unblinding yourself, Marge.
I'll accept that responsibility, except I can't get it to move.
So where do we do?
So I hit change.
Do we all need to vote again?
Oh, there it went.
We do.
Okay.
We all have to vote again?
Got it.
No?
Let's not all vote again. Let's just let Marge vote and see if our numbers change the way they're supposed to. Okay? Okay. So we have low value and reasonable value. And I would invite anyone to just say a few words about the reasoning process, because that's going to fuel all of our afternoon discussion. Health system value. Dr. Klingman.
I'd be happy to talk about this. We've had a lot of discussion here, I think, about whether this is a patient care problem or whether it's a public health problem or whether it's an ethical problem or whether it's a health care cost problem. I don't think it's any of these. It's a pricing problem. This is not a health care cost problem. This is all related to price. And we've heard the current costs, the affordable, in the standards of people that are, constrained, which is obviously Medi-Cal. If you don't believe Medi-Cal is constrained, you should come hear some of my doctors at ACCMA complain about Medi-Cal. That's across the board on what Medi-Cal can afford. And, they're sort of looking at having to only be able to treat a subpopulation. The reality is you can argue all you want that this is a great investment. And somebody told me I really should buy a casino in Vegas because I could make a lot of money. I'd say, well, gee, that's great. I can't afford it. And so that's where it comes down to. And I think that it's a pricing problem. And I think that fundamentally, at the current constraints, which are realistic, it simply will break the bank on public health deliverers, and it's a strain on everybody else. This is a country where we spend a lot of money on health care. And I'm with Sharon. I don't think to be in the position of saying, I'm sorry, we can't treat you because you're not sick enough, because I have to treat my multiple sclerosis patient with drugs that cost $65,000 a year. And at some point, I think we need to understand that this is a pricing problem. It's not a problem of anything else.
Thanks, Jeff. Others?
I would just add that it's not just a problem for Medicaid. I'm not from an insurance company, but like many people in the audience, I'm part of a system that is beginning to have a self-insured policy. So this really very directly affects anyone who's in a system where, to some extent, we all hold the purse strings. It's not simply Medicaid. It's not simply Blue Shield, Blue Cross. It's Cisco. It's you name the company that is actually partly self-insured, and there's an increasing need to be conscious on the part of all. And I agree it's a pricing problem, and it's pitting patients against each other. Is the MS patient worth more than the Hep C patient? And this is ethically unpalatable.
Thank you, Meg. Could we hear from a representative from the UC system or Stanford talk about how they've thought about this voting question?
I'll say I think a big issue was it was phrased as a Medicaid program. I think theoretically a much larger system will be able to handle this a little better. So I think for me the affordability is the key issue here, and I'll be agnostic on what is an appropriate profit for any particular drug. But I think looking at the value as a measure of affordability, in that case, very low likelihood that it can be afforded.
Thanks. Rob?
I was swayed by the cost to avoid one hepatitis C virus-related death being astronomical, exceedingly high at the outset because you're buying drug for a lot of people and it's taking many years for the benefit to accrue in terms of prevention of death. Now, I realize there's a whole lot more to this than dying from the disease, as some of the presenters discussed. So this is one piece of the puzzle. But then the other thing was simply the aggregate cost to the system I felt was unsustainable. So,
thanks, Mark. We have actually completed our voting. Mr. Chair, would you like to comment on your thinking and wrap this up before lunch?
My colleagues on the panel were eloquent in what they just said. I have nothing to add.
Very good. Karen, you want to help us through our logistics?
Yes, so thanks everybody. We're going to take a break now for 30 minutes.